It is starting at 1:30. It may take 2 hours to complete. More than 2 hours, I think.
Diameter is 0.012 millimeter compared to 0.
Sir, shall we start, sir?
Ultrasonic.
We can start, I think.
And on top of that, it's a non-contact contact.
IT person, are you ready?
These are the various instruments like IOL Master 700, which can
With the timer and everything?
No, sir, I have a question, Ashwin. Are all there are about 4 plus 14, maybe one more person, 14 people plus 3, 17 are there? Or are they going to be let in only one by one? There are a lot of people. Do we have the people who are involved?
No, sir. Sir, you note the individual.
No, sir. Same order order ಇದೆಯಲ್ಲ ಅದು
ಅಂದ್ರೆ ಸರ್ ಇಲ್ಲಿ ಯಾರೇನೋ ಜಾಯಿನ್ ಆಗಿದ್ದಾರೆ.
ಫಸ್ಟ್ ದೀಪಿಕಾ ಅಂತ ಇದೆ, ನೆಕ್ಸ್ಟ್ ಫ್ರೀ ಪೇಪರ್ 909 ಅದಕ್ಕೆ ಆತರ ಬಂದ್ಬಿಡಿ ಆರ್ಡರ್ಸ್. Deepika,
hello, sir. I'm Dr. Deepika, sir.
Okay.
Shall I start sharing screen, sir?
1 minute.
2 minutes. Yes, sir. You can start, sir.
Start now. Deepika,
yes, sir.
Can start.
You can start, sir.
Are you putting your timer there, or shall I time, Ashwin?
No. Sir, no, sir. You can start, sir.
No, timer for each paper.
Timer, sir.
Sir, I will time, sir. I have my timer.
Okay. Better, I think.
6 minutes, and for all participants, 6 minutes presenting time exactly,
yes,
and then followed by 2 minutes of discussion. Sir, can you start, sir?
Okay, we can start. Yes, we can start.
My screen is visible and am I audible, sir?
Audible and clear. You can start.
Okay, sir. Good afternoon, everyone. I'm Dr. Deepika N, presenting a paper on barriers responsible for the delay in presentation of patients with bilateral mature cataract, the chief author being Dr. Subrata Hegde. Cataract is responsible for 50 to 80% of bilateral blindness in India and around 40% of the blindness globally. In spite of having national program for cataract, there has been delayed presentation of patients to hospital. There is scarcity of local data about the profile of late presenters of cataract and its associated factors. Hence, the aim of our study is to evaluate the reasons for delayed presentation in patients with bilateral mature cataract. Materials and methods. The study was conducted with a study population of around 62 patients in Department of Ophthalmology in Tertiary Care Center. The duration ranged from August 2019 to March 2021. It was a prospective observational study. All adult patients with bilateral mature cataract attending OPD were included. Patients with significant mental illness and communication difficulties were excluded from the study. Methodology. The study population consisted of 62 people, out of which 34 were females and 28 were males. Patients were subjected to detailed history taking with an average duration of 15 to 20 minutes, including socio-demographic details like locality, occupation, and thorough ocular examination was conducted in the form of vision, slit lamp, and tonometry. Descriptive data analysis was conducted and reported in numbers and percentage. The results were tabulated as follows. We can see that age group was arbitrarily divided into 3 groups, 20 to 40, 40 to 60, and more than 60. Around 77.7% of the people belong to the age group of more than 60 years. This indicates that old age was a significant barrier for the delayed presentation of patients with bilateral mature cataract. Coming to the gender profile, there was a higher incidence of cataract in female compared to the male population in our study, with the ratio being 1.2:1. Moving on to the residents, we can see that 80.6% of the people in our study group belong to the rural area, because accessibility comes forth as a major barrier for the people residing in the rural area. And education was categorized into 4 groups. Around 93.5% of the people in our study group were illiterate, and only 3.2% went to the primary school. This is another significant barrier because this was the group of the people, they did not have knowledge about the cataract, they had fear of surgery, and even regarding the outcome of surgery. Some had an attitude that they have to wait until the cataract is ripe enough to undergo surgery, which was followed from earlier days. Coming to systemic ailments, hypertension and diabetes mellitus were the most common comorbidities found in our study, with the hypertension being a more common. Cardiac and renal disease were noted in few of patients. Moving on to the occupation, on 62.9% of the people were unemployed, because I already told majority of them were elderly and were dependent on someone for livelihood. And around 22.5% of the people belong to farmer or labor class, because most of them were from rural area. And this was the group of people who had financial concern, because they thought that there could be loss of daily wages if they went to the hospital for evaluation, and could be some additional transport charges also. And when we started evaluating the time period from the onset of bilateral defective vision to the presentation, we saw that around 66.12% of the people presented between 3 to 6 months, and around 21% took more than 6 months to present to the hospital. So when we started evaluating the reasons for delayed presentation, we found out that COVID pandemic was the most common cause for delayed presentation in our study, measuring up to 67.7%, wherein most of the people did not turn up for surgery in fear of pandemic. Transportation difficulties were noted due to lockdown. Hospitals were offering only emergency care because dealing with the pandemic was a major priority at that time. Lack of awareness was the second most common cause, measuring up to 14.51%, because most of them were illiterate. Old age with comorbidities measures up to 6.45%, because there was lack of supportive attender to accompany them to the hospital. Others being economic issue and insensitivity to female health. 5 of our patients expressed financial constraints because they thought that there could be out-of-pocket expenses if they visit during surgery or after surgery, and they were unaware of the fact that cataract is free under the national program launched by Government of India. Coming to discussion, in our study, most of them belonged to the age group of over 60 years and were females. In the study conducted by Nirmal and P. et al., reported lower number of cataract in males, which can be attributed to factors like lower nutritional status, cultural insensitivity to a female's health needs. Our study revealed that the most common cause for late presentation was COVID pandemic. Most of them delayed the surgery in fear of pandemic and lack of transportation facilities due to lockdown. The second most common cause was lack of awareness, as most of them were illiterate and were from rural area. In the study conducted by Lipi Chakrabarti et al., revealed that lack of awareness, old age, systemic ailments were the factors responsible for delayed presentation to the hospital. Coming to the conclusion, educational efforts related to cataract should aim to reach the rural population. The first being that cataract is free of cost under the national program, and most issues can be addressed through repeated counseling sessions by healthcare providers. There is a need for strategies to improve accessibility in the form of transportation, or conducting more frequent camps, or conducting camps in the areas which are very located farther away from the hospitals. Awareness in patients seeking delayed medical attention. COVID-related safety precautions should be taken in hospital preoperatively and intraoperatively, which may improve the uptake of patient. Thank you.
Yes.
Hello.
You can stop your share. You can stop your slide share.
Stop stay share. Huh?
Okay, sir. I'll stop.
Okay. So patients are from rural area or urban area?
In our study, most of the population was from rural areas, around 80.6%.
Okay.
Because my hospital is a tertiary care center, which caters to both the urban and rural population, sir.
Okay. Okay. Any questions, Chandrasekhar?
Yes, sir. If it had not been for pandemic, what would have been the percentage?
Yes, sir. Because 23 of the people we evaluated pre-COVID era, sir. In that time, I found that lack of awareness and old age and lack of supportive attenders were the most common cause for delayed presentation, sir.
So basically, now pandemic is a major cost for you, isn't it? But for that, awareness is better. Okay, you compiled good statistics, finished on time. Thank you, sir. Dr. Arvind, sir.
50% accuracy is acceptable.
We can move on to next
5%
topic.
is achievable. So we should strive for what is achievable and not for what is
Thank you,
acceptable.
sir.
We have to learn not only from our
Okay.
own, but also from other mistakes.
Hello,
That is,
sir.
that
I'm
is
Dr.
called
Jasmita.
smartness.
Can I share my
Validate-
slide, sir?
Yeah, go ahead.
Sir, next candidate, Jasmita.
Okay, let us start. Jasmita, no? Jasmita B.
Yes, sir. Jasmita B.
Start, sir.
So time starts now. 1 minute is there. I'll give a message.
Hello, sir.
Chat. Please
Okay.
start.
Okay.
So, shall I start, sir?
Ah,
Okay. Good afternoon to all the panelists. Today, I would, sir, some confusion with the presentation.
wait.
I have paused the timer.
Okay. So,
The slideshow is coming.
okay.
You move to the next slide.
Okay, so I would like to thank COSCON for this opportunity, and I would like to thank my guides, Dr. Mamta B and Dr. Rekha ma'am, for this wonderful opportunity. Today, I'm going to present about case series of COVID-19 vaccination related acute endothelial rejection in penetrating keratoplasty. So as we know, COVID-19 pandemic has affected several aspects of healthcare system, and ophthalmic practice is a no exception. And to curb this spread, government has taken stringent efforts to mass immunize the population. We know vaccine has been proven to be safe and efficacious. efficacious. But however, it comes with a minor immunological adverse effect when it comes to corneal transplantation. And we very well know the cornea is an immune privileged organ. However, the graft rejection rate is known to be 2.3% to 68% depending on the patient risk factors. A bit about vaccination causing immune response. In the literature, there has been proven reports that vaccination has been a trigger factor for corneal graft rejection in the past, especially flu shots for influenza. Vaccine incites immune response that can induce class 2 MHC complex antigen in all the layers of the grafted cornea and could trigger allograft rejection, just like influenza vaccine. And recent rampant vaccination against COVID-19 has also triggered the debate about the same such effect on endothelial or full thickness keratoplasty. So today's main concern is Covishield. Till date, 80 crore people have been vaccinated in India, and about 48 crore people have received both the doses of the vaccine. And in this case series, we are going to discuss the presentation of corneal graft rejection following COVID-19 vaccinations of Covishield, which is developed by Serum Institute of India. It is a viral vector vaccine carrying SARS-CoV-2 spike protein, and it has demonstrated a high levels of neutralizing antibody titers, antigen-specific CD8 plus and CD4 plus T cell responses. So in our case series, we have taken 4 cases who all underwent penetrating keratoplasty, and all were on maintenance dose of topical steroids, and 1 patient was on tapering dose of postoperative steroid regimen. And all the 4 cases presented to us with diffuse endothelial rejection. Among the 4 cases, the age ranged from 22 years to 70 years, and all patients, like I said, underwent penetrating keratoplasty for different reasons. Our first case was a female. Her graft duration was 18 months, and her visual acuity pre-vaccination was 66 parts, and she presented to us 25 days post-vaccination. However, she presented to us 10 days after the initial signs and symptoms of rejection, with her visual acuity at presentation was 660, and we started her on intensified topical steroid. However, due to the second lockdown, we again lost her for follow-up, after which she presented with the intense graft edema with endothelial rejection, with drop in the visual acuity to CF 2 meters. And then followed by that, we started her on oral corticosteroids, subconjunctival, and also intensified topical steroid regimen. However, we achieved clear graft within 4 months of her initial presentation with final visual acuity of 612 parts. Coming to the second case, a male patient whose graft duration was 5 months and visual acuity pre-vaccination was 6.9, and the duration of presentation after vaccination was 4 days, and he presented to us immediately within 1 day after the initial signs and symptoms, with visual acuity dropped down only to 6.9 parts, and he resolved within 3 weeks and with visual acuity improving to the pre-vaccination state of 6.9. Our case 3 is a female who had undergone penetrating keratoplasty in both eyes for macular corneal dystrophy. However, this particular eye, graft duration was 39 months and her visual acuity pre-vaccination was 6.9. With the duration of presentation after vaccination was 13 days. Again, she also presented to us immediately within 2 days after the initial signs and symptoms with a drop in vision to 6.12. And she also responded very well to topical steroids. Within 4 weeks, we achieved clear graft with 6.9 vision. Other eye also had undergone PK, like I said, showed no signs of rejection. And also we started her on prophylactic topical steroids when she presented to us immediately. And we have not seen a rejection in that eye so far. Our fourth case was a male, and he was his graft duration was 3 months. With visual acuity was 636 pre-vaccination, and he presented to us 9 days following the vaccination with visual acuity dropped down to 660, and he also responded well to the topical steroids within 6 weeks with the visual acuity same as pre-vaccination visual acuity with 636, and he also took second dose of COVID-19 vaccination 9 weeks post resolution. And we had started him on prophylactic topical immunosuppressive drugs and has shown no signs of rejection so far. So these are the few pictures showing keratic precipitates with acute endothelial rejection showing AC reaction and clear graft following resolution. So in our discussion, we have observed a resolution time of 3 weeks to 4 months. 4 months being delayed in only one case because of her late presentation and also loss for follow-up due to the lockdown effects. And we did not lose any of the grafts. In the literature, Steinman et al. Has reported a case series of corneal graft rejection following immunization for hepatitis B, tetanus toxoid, and influenza. Wessel et al. Has reported 2 cases of COVID-19 vaccine-related corneal graft rejection with resolution time of 3 weeks and 4 weeks. Philacto et al. Has also reported endothelial rejection following COVID-19 mRNA vaccine in cases of DMEC patients. Again, he also observed resolution time of 4 weeks to 7 days. And Rallis et al. Has reported a case of endothelial rejection in a patient who had undergone bilateral DSEC with one eye graft rejection, whereas the other eye graft remained healthy. And he also observed resolution time of 3 weeks. So to know about allograft rejection post-vaccination, we know that on exposure to activated T cell products, class 1 MHC cells are induced in the corneal epithelium and stroma. However, much stronger class 2 MHC can be induced in all the 3 layers of the cornea. So there are 3 possible mechanisms for allograft rejection. One,
Your time is up,
response causing
Dr.
soluble
Jasmita.
immune complex deposition in uvea and perineal vasculature causing inflammatory.
Your time is up. Your time is up.
Hello.
Causing
Yeah,
MHC
14.
Hello.
followed by
Jasmita.
Am I audible?
Second possible
Yes, sir. Yes, sir.
systemic
You are audible,
Switch
sir.
off your earphones.
causes which can reach
Hello.
the graft tissue along
You
with
can
Hello.
stop share. You can stop
causing
share.
MHC expression and then allograft rejection.
Jasmita.
The third
You can stop share.
productivity is metastasis,
You can
which
stop
can
share.
cross-react with allo MHC complexes already existing in the donor cornea, causing allograft rejection.
Jasmita, it's time over.
Yes, sir, Dr. Divakar.
Okay, in conclusion,
Can others,
highlight the possibility of immune
Hello.
corneal rejection following COVID-19
Jasmita,
vaccination.
can't you hear
All the
me?
corneal surgeons are aware of.
stop.
This leads us to a dilemma of timing of the
Let's
vaccine
stop.
in the post-grafted patient. Any standard
She has
He's not
taken off her
hearing it.
earphones, sir.
to
She
be
can't
followed
hear.
in the in such patients, and timing of the second dose of
Jasmita,
vaccine. is the
hello.
Ashwin, you can cut off. Ashwin.
Your slide is cut, sir.
Sir.
Thank you, and
You can mute her. When time is up,
Hello.
you can continue. You put your earphone. Can you hear us, Dr. Jasmita?
Can you hear? You can't hear, no?
Dr. Jasmita, can you hear us?
yes, sir. Yes, sir.
Okay. You exceeded a lot of time, when you say stop. Yes, sir, Dr. Divakar.
I think you should subtract the time. No, timekeeper we should do correctly because 6 minutes and 2 minutes per discussion. You already exceeded 8 minutes now. More than 8 minutes actually.
Ashwin, can you mute yourself?
And how do you say this is due to vaccination or the other causes of rejection, no?
Sir, most of the patients were already on the maintenance dose of topical steroids. However, also the temporal association of the graft rejection to the vaccination timings could be one possibility, sir, because no other reason we could find in graft in such patients to correlate for rejection, sir.
Okay. Any other questions?
You could have, you've got only 4 cases. I would have been happy if you had put patient 1, these are the findings, not some features, You always identify the patient, what is the finding and explain. It would have been a little clearer. So, okay, we can move on, sir.
We can move on to the next.
Thank you so much.
Thank you, sir.
Next presenter, please. Writer,
Aitaraju.
yeah.
Hello.
Peekaboo, we can't see you.
Aitaraju.
Yeah.
Sir, just a minute. I'm just calling him.
If you're not coming, then you have to leave. No, don't bother.
Okay.
Hello.
Sir, she came, sir.
Hello.
She came, sir. Yes. Are you audible?
Yeah. Am I
Okay.
audible? Yeah.
Yes.
I'm Dr. Aitaraju Manognya.
Okay.
I'll share my screen. Is my screen visible?
Yes.
Good afternoon, everyone. This is Dr. Manognya. Today, I'm here to present an interesting case that we have seen in our OPD. I've named it. Okay. Just 1 second, sir. My video is visible, sir?
Go ahead. Nothing is being over. You're
Okay.
seeing the first slide.
Okay.
You're not into slide share at all.
Yes.
Yes.
Yeah, okay, sir. I'll start now. Hello, everyone. I'm here to present an interesting case. I named it as Peekaboo, we can't see you. It's an interesting case of refractory glaucoma secondary to occlusive vasculitis of probable viral etiology. So I'll go into a brief case report. She is actually a 26-year-old female. She presented to us in April 2021 with history of sensitivity to light in the right eye and right-sided headache since last 1.5 months. She was seen elsewhere some around 1 month back, and she was told to have high intraocular pressure. She was started on tapering doses of lotepredinol and brimonidine, which she stopped by herself after 1 month because there is no change in symptoms. She had no history of trauma or redness or previous such episodes. There were no history of febrile illness or any other systemic problems. She had no history of steroid usage in any form, but she gave a recurrent painless oral ulcer history between the age of 18 to 22 years, which relieved with multivitamins. There was no history of any genital ulcers. There was no significant family or travel history. So I'll briefly go into the examination findings that we have found. Basically, all the problems were there in the right eye. So I'll just brief the left eye. Left eye had a sphere error of, or a spherical error of 3.75. The best corrected visual acuity 6/6, and everything was normal in the left eye. In the right eye, I'll go into the details of the examination. Her best corrected visual acuity was 6/9. She had a spherical error of -4. Her color vision and Amsler grade was normal. Ocular movements was normal. Intraocular pressure checked with GAT at morning 10:30 was 35 mm in the right eye, left eye 17 mm. Into the anterior examination findings, the cornea was clear, there was no KPs, the anterior chamber was quiet and normal depth, the iris was normal, there was no NVI, a pupil, there was a grade 1 RFPD, the lens was clear, we have done gonioscopy, right eye was open angles, there was no NVA, no synechiae, no other pigment clumps or any other changes, it looked absolutely fine. Her central cornea thickness was 544 in the right eye. Coming to the posterior segment examination, her AVF was quiet. Optic disc was 0.7 CDR with inferior and thin, that's noted. Her macula was normal. In the fundus examination, we have found sclerosed arterioles in all the quadrants starting from mid-periphery. Posterior pole was normal, only the sclerosed arterioles were there from the mid-periphery. Veins were normal in caliber, there was no crossing changes. Periphery was normal, the pars plana was clear. In the left eye, everything was normal. This is the right eye fundus photograph showing a 0.7 CDR with inferior and thin. This shows the whole fundus picture showing the sclerosed arterioles in all the quadrants. You can see from mid-periphery everywhere there are sclerosed arterioles in all quadrants. Here, this is the right eye. Left eye, everything was normal. OCT right eye macula was normal. OCTA right eye was also normal. This is we have done FFA to rule out the reason for arteriosclerosis. So this shows the perfusion of only the posterior pole, and there is complete non-perfusion from the mid-periphery. And there is in the mid phases and late phases, we could see some fern-like pattern in the posterior pole. This is showing the non-perfusion of the mid-periphery. Left eye FFA was normal. This is the fields done on Elizar. Both were reliable fields. Right eye, there is a superior arcuate depression corresponding with the inferior and thin. Left eye, there were only few edge depressed points. Her BP was normal, her pulse was equal, and pathology test was negative. So we came to differential diagnosis. Basically, we kept two things in mind. One is occlusive retinal vasculitis. Secondary to either systemic vasculitis like SLE or PAN or viral etiology, or a systemic disease that's causing the occlusive vasculitis, or rarely primary ocular syndromes. And second differential diagnosis we had was an occlusive vascular disease. We were more inclined towards a retinal vasculitis because there was a hypertensive component that is there as well. So we have began the systemic workup. The CBC was normal. The ESR was 50 mm, sorry. CRP was 2.1. RBS was normal. Peripheral smear was normocytic, normochromic. In the torch panel, she was IgG CMV and IgM herpes positive, herpes simplex. Anti-treponemal antibodies were negative. HIV and HPSAG was negative. ANA, ACE, C-Inca, P-Inca, everything was negative. Homocysteine was normal. Protein C, protein S was negative. HLA-B 51 and 52 was negative. Carotid Doppler and vertebral Doppler we have done to rule out any occlusive vascular disease, and it was normal. And MRI brain with contrast was done to rule out multiple sclerosis. It was normal. But the IOP remained high in the range of 35 to 40 despite maximum AGM and oral estozolamide 250 mg QID. Because we gave a trial of topical steroids as well, prednisolone acetate, but the IOP increased to 52, so we had to taper and stop. A trial of antivirals were also given because she was IgM, CMV, and IgG positive. We gave valcyclovir 1 gram TID for 2 weeks, but there was no response. But IOP remained high, so we had to take up for immediate trabeculectomy with mitomycin C under topical anesthesia. Post-trabeculectomy, she was doing very fine. She had a very diffuse cystic black AZ was formed. Her IOP was 9 mmHg even at 3-month follow-up. Her best corrected visual acuity was 6 parts and N6. She was not any AGM as of now. So this was an interesting case where we couldn't find the cause actually because she has the occlusive vasculitis and increased pressures, but there were no changes in the anterior chamber or in the angle, and everything looked normal. So just I wanted to open the discussion. Any questions?
You can stop your share.
Okay, sir.
You finished the presentation?
Yes, I have finished.
Okay.
You brought it for discussion.
Yes, sir.
You stopped your share.
Stop share, side share.
Yeah. Okay, sir. I've closed it, sir.
So it is a secondary glaucoma or a primary glaucoma?
It's a secondary glaucoma is what we were thinking, sir.
Okay, okay.
It's only one eye.
What is GAT? You have to tell the
Goldman applanation tonometry. It was 35 mm. Yeah.
Okay, you should.
Okay, sorry. Yeah.
Okay, okay.
Only standard abbreviations like DNA can be
Okay.
used, you know.
Okay, okay.
This may be your hospital.
Okay.
Yeah, okay. So it's a
Okay,
case
sir,
report
sorry.
only.
Yes, yes.
Okay.
It's not a paper, free paper, no, it's a case report what you have done.
Yes, it's a case report. Yes.
Okay, okay. Arvind, you are muted. You can ask questions.
Sir, you're muted.
I couldn't
sir.
hear. I couldn't.
Yeah, 1 minute.
Yeah.
Dr. Arvind, sir, you're muted. No, sir, you're muted. You're not able to hear. Sir? You're muted, sir.
I think
Okay. Shall we move on, sir?
we can move on to the next case. I think.
Shall we move on, sir, to the next case?
We can move on to the next case. I think it's better.
Thank you.
Thank you, sir. Thank you.
Next presentation.
Sir, next Kavita.
Kavita from 1252.
Yes, sir.
Kavita way it is.
Okay,
So
Dr.
there are two
Kavita.
Kavitas, so if I can, am I audible?
Now, what is your topic?
It's about orbital anthropometry, sir, orbitofacial anthropometry.
Correct, correct.
Yes, I think you can go on.
There are two Kavitas, so I just wanted to.
No, you're the one.
You are the one. Yes.
Can I start sharing, sir?
Yes,
I can start
ma'am.
sharing.
Your time starts.
So I have no financial interest in this presentation of mine, which is on analysis of orbitofacial anthropometry in children with features of pseudostrabismus. Orbitofacial anthropometry deals with the measurement of inner canthal distance, that is ICD, outer canthal distance OCD, palpebral fissure width PFW, IPD, that is interpupillary distance, and canthal index, which has a formula to be calculated. Pseudostrabismus is a condition which there is an appearance of strabismus, but actually there's no true misalignment of the eyes. So this can be seen in situations like telecanthus, presence of epicanthal fold, hypertelorism, and euryblectron. This condition can be present in isolation or in combination in various craniofacial, orbitofacial syndromes and congenital deformities or anomalies. Hence, we wanted to study this, and so that these anthropometry data helps in diagnosis of craniofacial anomalies or orbitofacial syndromes, especially what we are dealing with is blepharophimosis syndrome, Apert syndrome, and Clausen syndrome. It helps in the management of various surgeries dealing with craniofacial, orbitofacial areas and lid areas, so that there's better function and cosmesis, especially so following trauma. It also helps in genetic counseling of unaffected family members. So some of the family members may have only partial features. So in that case, it helps in genetic counseling. It helps in making of spectacle frames and lenses, optical display devices, most interestingly, prosthodontics and forensic medicine. Hence, our aim was to analyze this orbitofacial anthropometry in children with specifically in features of pseudostrabismus, and to analyze these parameters in different age groups and between genders, And lastly, we also compared the measured and calculated IPD. So ethics committee approval was taken before the study started. Informed consent was taken from parents. 60 children were recruited aged between 6 months and 18 years with features of pseudostrabismus. Those with lid or pupillary abnormalities and in-home measurements were not feasible, and with craniofacial and orbital deformities and children with developmental delay were excluded from the study. All the measurements were taken by a single person. 2 readings were taken using a digital vernier caliper. The parameters calculated or measured were ICD, OCD, PFW, and IPD. So Canthal index was calculated based on this formula. This is ICD into 100 divided by outer canthal distance. Earlier, there were a couple of formulas which were derived. It was meant only for Western population. That is Pyro's formula, which was came up in 1969, and Feingold and Bozart in 1974. After that, in 1983, Singh et al. Came out with our one formula, which I mentioned below, separate for male and female. It was a multiple regression formula, and this suited our Indian population. So in our study, we adopted this formula so that it can be closer to that. And we wanted to compare how this calculated IPD is with the measured IPD using PD scale or any scale, ordinary scale. Further, these children were divided into 2 groups, less than 2 years, 3 to 5 years, 6 to 10, and greater than 10 years. All this data was analyzed statistically. These are the few pictures where we are using the caliper. And the central picture is where we can't really measure the IPD because the child may not be cooperative, but the same can be done with caliper using when the child is sleeping. In our study, the male population or male children were more, 55%. And when we compared the lid features, it was telecanthus, which was more common. Mean values in males and females were compared, and we found that all parameters except calculated IPD was found to be statistically not significant between either sexes. Furthermore, we analyzed in sub-age groups, both male and female, and we found that all parameters except ICD and Canthal index in male and female were found to be statistically significant, which indicate, and there was no difference when compared to between age groups. This indicate that ICD had no much change with the growth. All except Canthal index were higher in male in all age groups except less than 2 years and greater than 10 years, where the values were higher in female. So this is a scatter plot diagram, which the significant correlation was found between measured IPD and CIPD in both male and female, and also between age groups. So other studies analyzed orbitoanthropometry in normal individuals to obtain normative data. We analyzed specifically children with pseudostrabismus. As far as our literature search till today, we found that there are no similar studies. In our study, additionally, we compared the measured IPD and calculated IPD. Measuring IPD might be very cumbersome in children who are not cooperative, who have poor fixation and having developmental delay. Therefore, we wanted to check out whether both are having any correlation, and this can be used only if there is a positive correlation. And we did find a significant positive correlation between the two. And we found that there are no other similar studies. To conclude, our study does have, like any other study, few limitations. It wasn't a longitudinal one, and we didn't recruit equal numbers in the sub-age groups. But orbitofacial anthropometry values which we got in pseudostrabismus children may contribute to normative data. It can help in retaining ethnical features following orbitofacial or lid reconstructive surgeries, especially following trauma. It also helps in counseling parents during follow-up that the squint is pseudo and not true. It could be in pseudostrabismus children or post-squint surgery. It helps in counseling the parents. Lastly, calculated IPD can be a simple alternative for spectacle frame and lens making in children where measuring IPD is cumbersome or difficult. These are our references. Thank you.
You can stop slide share. Thank you.
It was the same study in Singapore or China population. Any difference will be there?
Sir, I didn't hear you, sir. Sorry.
If you do the same study in other countries like China or Singapore, any difference?
Intercanthal distance will be more, sir, in East Asian countries.
Okay.
ICD will be, intercanthal distance will be more. So telecanthus feature will be a more of a common feature.
Okay.
And also the palpebral fissure width, they have found lesser, in very much lesser in East Asian, that is Singapore and Malaysia, compared to our South Indian and Sri Lanka. South India and Sri Lanka are matching, sir. Likewise, the East Asian is matching, and Northern India is the Aryan race. So they have different parameters. But we didn't include, take the foreign formula.
Okay.
However, we had only one formula to fall back. That was the Singh et al. Who came out with a multiple regression formula. So we use this because in our practical problem, we are having a problem to give spectacles, especially children less than 3 years or so, where measuring the IPD is difficult. So we wanted to compare and see.
Yes. Dr. Arvind, sir?
Yes, sir. Good study.
Thank you, sir.
You didn't work up for
Can I
exorbitism,
call
no?
the
In
next
this?
candidate?
Sir?
No, exorbitism, you didn't work for this.
Sir, I didn't hear you.
Exorbitism, did you try and work out when it was bigger? The distance was bigger. No, okay. No problem. Thank you so much.
No, we didn't analyze
Yeah,
that.
yeah, thank you.
Thank you, sir.
Sir, can
Next
I call
candidate,
next
please.
candidate?
Vandana, correct?
Vandana, she's in out of station, sir.
Okay.
Sir,
Then
I
next
just called her.
Okay, next candidate only.
Sunaina.
Sunayana.
Yes. Hello.
Yeah.
Yes, I'll just share my screen.
Okay, ma'am.
Yes, Sunana, please share your screen.
Yes, sir, just sharing it.
It's taking so much time.
Just a minute, sir. I'm just sharing it.
Okay.
All the others, please keep your PowerPoint ready so that when we say you must share immediately, you have 6 minutes to present. Timing will fetch marks. So at the end of 1 minute, when there is 1 minute, I will put a chat that there is 1 minute more. You must have your PowerPoint ready on your desktop or wherever you are presenting from, because we are short of time.
Yes.
You're presenting from a car, huh?
Yes, sir. Yes, sir. It'll open, sir.
Hope you're not driving.
No, sir. I'm not.
No, if it's not ready, we will take it. You are not able to present. It is not coming on slideshow.
Can you move ahead with the next speaker, sir?
Yes, sir. Shweta. To get it ready, we'll have Shweta, sir.
So Shweta here, sir.
Yes, please.
Shall I start sharing?
Yeah.
Is my screen visible, sir?
Not yet. You could go to screen, full screen, slideshow.
Is it visible now, sir?
Yeah, you can start. Time starts now, 6 minutes.
Good afternoon, everyone. My study is titled Idiopathic Epiretinal Membrane and its Novel Association with Hyperreflective Foci. We do not have any financial interest. This was the inception of our idea. A 65-year-old male patient came to us with an NS2 grade cataract with a BCVA of 612 and 12 with an ERM, idiopathic ERM. This is the OCT of this patient. He was posted for combined phaco-IOL with vitrectomy ERM peeling surgery. These are the pre and 3-month post-op pictures of this patient. The pre-op BCVA, like I told, was 612 and 12, but 3 months later, the visual acuity was 618 and 18. Also, the central macular thickness increased from 335 to 367, which you can observe in the picture here on the topography map here. The comparison of OCTs shows that though the ERM has been peeled well and the traction has been relieved, the macular thickness is persisting. So we were wondering what could be the cause for this persistent macular thickening even after 3 months of surgery. So we went back to the pre-op OCT image and did some observation. So this is what we found. There were few small white hyperreflective dots noted in different layers of the OCT. So this could just be an incidental finding. So we went back to more OCTs of more patients with ERM, and we found this amusing thing. These hyperreflective dots were present in many of these patients. This was interesting because
hyperreflective foci in ERM is not a very commonly known entity. There was only one study that has reported this. So we wanted to see further into this. So we did a study to find the novel association of hyperreflective foci with idiopathic ERM. So this was a retrospective observational study of patients who underwent surgery for primary ERM between Jan 2018 and Jan 2020. We chose patients with symptomatic ERM and macular thickening who were treated with PPV, ERM, and ILM peeling with or without adjuvant steroid, depending on the surgeon's discretion, with a follow-up of at least 1 month that should have been available. So we excluded patients with other retinal abnormalities that could also cause ERM, ocular inflammation, advanced cataract including OCT, and uncontrolled systemic diseases. So we collected data of demography and BCVA at baseline and every postoperative visit. All patients underwent swept source OCT, radial scan of 12 into 12 millimeters centered on the macula. The images were graded by 2 independent assessors. All 12 scans of baseline and each follow-up were assessed, and average was taken. We used this EVV feature for counting hyperreflective foci. Let me show you what it means. Topcon OCT machine has this unique feature called enhanced vitreous visualization. The top picture shows the normal OCT view. Once we put on the EVV on, we can select the value that we want. So this does not basically change anything. It just makes the contrast better. So in this EVV -3, we can see that the hyperreflective foci are delineated better. So that was useful. So we used the Goveto classification to classify the ERM in our patients. Statistical analysis was performed using SPSS 22.0 software. A p-value less than 0.05 was considered statistically significant. So we could recruit 24 eyes into the study. 5 of them had stage 2 ERM, 14 were having stage 3, and 5 of them had stage 4 ERM. The mean hyperreflective foci were about 4.2 in stage 2 ERM and 32.07 in stage 3 ERM. As we move higher up, we see that a whooping 59.2 hyperreflective foci were present in stage 4 ERM. Also, the central macular thickness was seen 290.18 at baseline in stage 2 ERM, 319.68 in stage 3, and 412.74 in stage 4 ERM. This significant correlation was noted between the stage of ERM and the hyperreflective foci and CMT. So what was the clinical implication of this? So this is one of the patients who was part of our study. The pre-op picture shows a stage 4 ERM with significant traction and macular thickening of 554. Pre-op visual acuity was 636 N36. Patient underwent phaco-IOL ERM peeling with injection dexamethasone implant. Post-operatively, 1 month later, the BCVA was 6.9 paths and N10. The central macular thickness had come down from 554 that you can see in the topography map to 448, with patient outcome being better. So this is another patient who had a stage 2 ERM who was also part of our study. The pre-op visual acuity was 612 N12. The patient underwent PPV with ERM peeling alone with no adjuvant steroid. The best corrected visual acuity was still good here, 6.9 N8, and the CMT reduced from 304 to 232. So we compared both groups, those that received steroids and those that did not. And we found that 3 months down the lane, patients who had received adjuvant steroid during the time of surgery showed a significant decrease in the hyperreflective foci. This again could show us that these hyperreflective foci could be inflammatory in origin. So we found that the number of hyperreflective foci increased with the stage of ERM. This correlates with the fact that these are postulated to be a product of degeneration and inflammation. So the increase in number of hyperreflective foci corresponds to more severe stages of the disease. Similarly, we also found that the mean CMT was higher in patients with higher stages of ERM. So the implication is, in summary, our study showed a novel association of hyperreflective foci with severe ERM, that is stage 3 and 4. We can consider intravitreal steroids as adjuvants in stage 3 and 4 ERM along with ERM peeling. Stage 1 and 2 ERM do not necessarily need any adjuvant. Most importantly, it is keen observation on the part of the surgeon before taking up a patient for surgery is important to not miss these tiny findings which could cause a difference in the outcome. Thank you so much.
Stop sharing. Stop sharing.
So was there any IOP search in that group, Ojudex group?
No, sir. No, sir.
No.
We had only
not a single patient.
Yes, sir. We only had 6 patients in that group, sir. Fortunately for us, none of the patients were steroid responders.
So do you feel it can be used as a biomarker in association with the prognostic factor?
Yes, sir. We feel so, sir. But the second part of the study, we are still trying to improvise and take a bigger number and figure out if it really can be used as a biomarker. Right now, the data is very less.
Why the follow-up is also only of 3 months?
Yes, this was a retrospective study, sir, and it was done during the pandemic. So the follow-up was affected because
prospective would have been a better.
Yes, sir. Yes, sir.
With a longer follow-up period.
Yes, sir.
Okay, good presentation.
Thank you, sir.
No other cross-references? Any other similar reports?
Sir, only one study is there, sir, in Omen Journal
nothing
of
else.
Ophthalmology. And that again, like sir told, they have considered this as one of the biomarkers, but they have not found much significance in their study.
Only that is the only one, no?
Yes, sir.
Thank you, sir. Dr. Devakar.
What is the cause of epiretinal membrane in all these most of the patients?
Sir, this was idiopathic ERM, sir. We could not find any cause. None of the patients had any secondary underlying retinal disorder. We excluded all those kinds of patients.
Okay. Thank you.
Is the previous speaker ready?
Sir, next candidate.
No, Sunanya is there ready. She can present. Otherwise, we can't.
Sir,
that is the turn for them.
Sunaina, 1 minute.
Sunaina is there and
Sunaina, are you ready?
Vandana is over, I think. No, Vandana? Number 8 and 9 both are not finished.
Vandana not absent, sir. Absent.
Absent, huh, Vandana? Okay. Now next is Risha and Risha is there?
Yes, sir.
You can start presenting.
Yes. Sir, is my slide visible, sir?
Yes, it's visible.
Not yet, sir. Not yet.
You are visible. Slide is not visible.
Okay, 1 second. Sir, is the slide visible, sir?
Yeah. You can start. Your time starts.
Okay. A very good afternoon to all the panelists. Myself, Drisha Sudev. My paper topic is a straightforward technique of intraocular foreign body removal using Endomagnet. Moving to the introduction, intraocular foreign bodies are defined as intraocularly retained unintentional projectiles that require urgent diagnosis and treatment to prevent blindness or globe loss. Intraocular foreign bodies are seen in 17 to 40% of penetrating ocular injuries, of which 58 to 88% enter the posterior segment. The location and damage caused by an intraocular foreign body depends on several factors, including the size, shape, and composition of the object at the time of impact. The prognosis for vision is dependent on confluent predictive factors like age, length of the wound, the time between the injury and repair, volume of intraocular foreign body, and complications like relative apparent pupillary defect, retinal detachment, and endophthalmitis. The history of the patient. A 20-year-old male presented with history of trauma to left eye with a metal piece. The patient complains of a diminution of vision in the left eye associated with pain and redness. There was no history of previous ocular trauma or surgeries, no history of any systemic illnesses. Moving on to ocular examination, right eye was found to be within normal limits. In left eye, vision was 6/60, not improving with pinhole. Conjunctival congestion and chemosis were present. And in the cornea, a corneolimbal tear of around 4 millimeters was found at 4 o'clock position, which was Serrel's positive. Also, another scleral tear was present at 1 o'clock position, 15 millimeters away from the limbus, with foreign body protruding through the wound. Pupil was 3 millimeters round, regular, and reactive. Anterior chamber was irregular and had hyphema of around 2 millimeters. In the lens, an intralenticular foreign body tract was seen. Fundus was not visualized in left eye. In anterior segment, we can see a corneolimbal tear, which was Serrel's positive. And here another scleral tear with foreign body seen protruding through the wound. An X-ray orbit was done, which showed evidence of a linear radiopaque structure seen in left orbit in superolateral quadrant, measuring approximately 1.2 centimeters in length, suggestive of a metallic intraocular foreign body. The patient was taken up for surgery. Wound exploration and primary tear repair was done, plus intraocular foreign body removal with endomagnet was performed. Post body was retrieved, and a postoperative B scan was done, which showed hyperreflective echoes suggestive of vitreous hemorrhage, and also an increased retinochoroidal thickness was noted. The patient was followed up after 1 week of systemic steroids and systemic antibiotics, and was found that the vision was improved to 6/18. Fundus examination showed resolving vitreous hemorrhage. Moving on to discussion. Definitive management for intraocular foreign body is surgical, which is to be ideally performed within 24 hours of the time of injury. Surgical technique depends upon the location of intraocular foreign body. Most common location is posterior segment. These intraocular foreign bodies can be removed by either external approach or internal approach, that is vitrectomy. In case of a magnetic foreign bodies in the region of pars plana, transmural extraction of intraocular foreign body using endomagnet is preferable due to lesser incidence of complications and optimum visual prognosis. Conclusion: endomagnet is an effective tool in transmural extraction of metallic intraocular foreign bodies and is associated with a good visual prognosis. These are my references. Thank you.
So, what are the limitations or when not to use endomagnet?
Sir, I couldn't hear you, sir.
Can you hear me?
Yes, sir. Yes, sir.
When not to go for endomagnet removal?
Sir, if the foreign body is more posterior, with more posterior segment involvement, it is better to do vitrectomy. And if there is associated vitreous prolapse or vitreoretinal traction or retinal detachment, it is better to do a vitrectomy.
Okay.
In case of also the foreign body should be metallic or of magnetic property to use an endomagnet. For inert non-metallic foreign bodies also, it is not applicable.
Definitely. It can be used only for removal of metallic foreign body only.
Yes.
Okay. Okay. Thank you.
There are foreign bodies in both eyes, no? Right eye and both eyes foreign bodies are there?
No, sir. Only left eye, sir.
Left eye.
You took only one X-ray, isn't it? Nothing else.
Yes, sir. The patient presented to our hospital.
No. What X-ray? What view did you take?
Sir,
did you try anything to localize where exactly? You said IPMA was there. Usually, X-ray technique
the
you
patient
can isolate.
presented from periphery to a hospital with the reported X-ray, sir, and we saw that sir.
Yeah, go ahead. We can hear you. Go ahead.
Sir, I'm not able to hear properly, sir. Sorry.
I'm not clear, huh? Sir, am I clear, sir?
Yeah, you are perfectly audible.
I want to know how did you localize, especially with IPMA?
Sir, sir, the patient presented to our hospital with already he had taken X-ray from peripheral center and it was reported by a radiologist, sir. It showed the location. And also we could see the foreign body protruding through the wound, sir, the scleral wound.
So from there only, you did not go inside at all?
No, sir. We just did a wound exploration.
Foreign body and remove.
Yeah, just did the cryotherapy for that retinal tear and we could easily retrieve the foreign
no pieces
body.
inside or anything? Okay.
No, sir. It was a single piece.
Good. Thank you.
Can we do MRI in such cases?
Thank you.
Sir is asking whether you would do an MRI for this case if you have not had the X-ray.
No, sir. If CT is the most CT is the most perfect tool for localization.
Why no
MRI? In case we can do MRI only if we are 100% sure that it is not a metallic or magnetic foreign body.
Can we move, sir? Next. Thank
you.
You.
Sir. Yes, sir.
Yes, sir. Who's next? Golap Gayatri.
Sir, can I call Sunaina?
Oh, yeah. Okay.
Hello? Yeah.
Sir, it is an Sunaina FP825, sir, who missed out.
Yes, sir. Yes, sir.
Yeah. You can share.
Yes, sir.
About 6.
Yeah.
And then you have 5, 6, 4.
Sir, are you?
Yeah, we
Yeah,
can
that
see
is
the
mine.
slide. Go to
Okay.
slide show and then start.
Yes, sir, sure.
The slide time starts now. Go ahead.
Okay. Yeah, okay. Very good afternoon to everyone. I'm presenting my paper today on transposition for malposition. Next. So here I'm, yeah, if you go to the next slide. So here I'm presenting a
Ashwin, can
case
you mute
of
Ashwin?
traumatic.
Ashwin, please mute.
Sir, just a minute.
Go ahead.
Yeah, please change the next slide. Yeah, so here I'm sharing a case of traumatic strabismus, where
we are not seeing your next slide.
they have to change it, sir. It's with the admin itself. I'm not controlling this one.
Ashwin?
Yeah, so I'm dealing with a case of traumatic paralytic squint. It's a condition where there's an ocular misalignment giving rise to incapacitating symptoms of diplopia when vision in both eyes are intact. The cause can be because of injury either at the muscle level, the neural level, intracranial level, or the orbital level. Normally ends up with an unacceptable cosmetic appearance along with symptoms like diplopia, and treatment is closely related to cause as well as the symptoms associated with it. Next slide, please. Yeah, so the purpose of this paper is to learn how to manage a traumatic paralytic squint without inducing anterior segment ischemia. Next slide. So we had a patient who was a 58-year-old male who presented with us with double vision binocularly, which worsened on looking over to the right side from 1.5 months at the initial point of presentation due to a road traffic accident, which led to a head injury. He had minimal symptoms on turning his face to the right side and also when one eye was closed. No other symptoms were associated. He had no other comorbidities. Next slide, please. So this was a picture of how the patient first presented to us. You can see a deviation in the right eye. Please go to the next slide. So on examination, we saw that he had a visual acuity of 6.9 parts in the right eye and 6.24 in the left eye with neovision of N36. He came up to 6.9 both eyes with correction, that is refraction correction with N6. IOP and color vision were normal. And seeing that the head posture, he had a slight turn to the right side. And on Hirschberg's test, it showed that the corneal light reflex was displaced about 30 degrees temporally in the primary position in the right eye. Yeah, next slide. So anterior segment examination was grossly normal. Next slide. There's no findings. Even the fundus examination was normal. There were no findings. Next slide. So here on motor evaluation, we saw under cover-uncover test, we had alternating ESO with left eye deviation more than the right eye. Alternating cover test shows secondary deviation was greater than the primary deviation. And on prism cover test, we found with base out prism that there was a deviation of about 50 prism diopters. And this was with left eye fixing. FDT was positive. So in these findings, we did it after some time. That was after 6 to 8 months when he came back for follow-up. Next slide, please. When seeing the uniocular movement, right eye dextro, the abduction was affected. That was showing a power of -3. The left eye had all full binocular, full uniocular movement. Next slide. On binocular movements, the dextro elevation, dextroversion, and the dextro depression was compromised, but the levo side, that's the levoversion, elevation, and levo depression were normal. Next slide, please. So here we can see that this is the pictorial representation of how the patient's eyes were moving. Next slide. So the diplopia showed increased, diplopia starting showed diplopia in the right gaze, whereas in the center, in the primary gaze, it was minimal, and the left side, there was no diplopia. Next slide. On on his charting also, which we did, shown that in the right eye, there was abduction limitation with exaggeration of the adduction on the left side. Next slide. What 4-dot test confirmed that there was diplopia, and CT MRI films were normal. There are no findings here as well. Next slide, please. On conclusion, we came to a diagnosis that this is a right lateral rectus palsy secondary to abuse and nerve injury due to cerebral trauma. We advise surgical correction to the patient after keenly observing him for about 6 to 8 months because of his incapacitating diplopia symptoms. Next slide. We chose to give this patient a modified Nishida's correction, where we did a right medial rectus recession by 6 millimeters from the insertion point using a 6-0 Weichel. Then we did a temporal 1/3 belly of the superior and inferior rectus, which were sutured on and the superior temporal, inferior temporal quadrants respectively, about 10 mm behind the limbus. Next slide, please.
in these intro-op pictures, okay, this is a picture showing how it was done, where you can see the bellies of the superior and inferior rectus being sutured. Next slide. So we took the medial rectus, we recessed it. Next slide. Then you can see that in the next slide. So we can see that in the next, the inferior and the superior rectus bellies were being tied to the superior temporal quadrant. Go to the next slide, please. And to the inferior temporal quadrant here. Yeah, next slide. Yeah, so it was finally we got a post-op correction for the patient. He had improved abduction. You can see in one of the other picture where he's seeing to the right side, and it was maintained even 6 months post-operatively. Ocular alignment was orthophoric. Go to the next slide, please. So this is why we used this procedure was because initially there was a Hamilton-Jensen's procedure, which was very risky because it would lead to anterior segment ischemia because it involved tenotomy as well as vertical muscle splitting, also giving rise to vertical deviations post-operatively. Next slide, please. So then Nishida came up with another procedure where we operate on multiple muscles, about 3 muscles at a time, without causing any anterior segment ischemia. So this gave rise to the no split, no tenotomy technique. Initially, Nishida also did a no tenotomy split. Then he went to a modified technique with no split and no tenotomy. Go to the next slide, please. So what was the whole principle behind this was when we sutured these lateral muscle bellies of the vertical recti, it created a additional muscle insertion point, and which gives rise to newer actions. That means it would generate more abductional force at the suturing point. Next slide, please. So this correction obtained with just the vertical muscle transposition was 30 to 35 PD, along with medial rectus recession gave rise to 50 PD correction. So overall, the entire abduction was also improved, and there was no anterior segment ischemia, no vertical deviation. Next slide. So in conclusion, I would like to say that modified Nishida is a very simple procedure to perform with minimal muscle trauma, no anterior segment ischemia, and also no ocular cardiac reflex to the patient. Thank you so much. The next slide shows my references. Yeah, these are my references. Thank you.
So what is the importance of sixth nerve palsy?
Like sixth nerve, because there is the lateral rectus involved, like initially we would think of like it could be very common in diabetics, and it's also because of trauma is another important cause for this, and it can also be a false localizing sign in case of an increased intracranial pressure.
But here everything else was normal, no? In your case?
Yes, sir. Everything else was normal. Only history given by the patient was trauma, sir.
So how many cases have been done using this technique?
So like this was my just one case which I have reported here, sir. But like the literature which I have referred, around 30 cases have been operated, and they all have shown to have no anterior segment ischemia, and they've achieved good correction as well. So about 30 to 35 PD alone, just by the suturing of the belly, the vertical recti.
So what further you suggest in modifying this surgery to have a good intorsion and extorsion movement, because that will be a problem with such kind of deviation.
Yes, sir. In order to prevent the intorsion and extorsion, so like to prevent problems with that.
Hello, can you hear me?
I didn't get you. I didn't get you, sir. Can you please repeat that?
So what further modification we can do in this technique?
We can also do a after like the primary procedure. We can also give prisms to the patient, sir, or in the post-op period, even do the resection of the lateral rectus in a later date.
Okay. Thank you.
Thank you, sir.
Shall we move on, sir? Next.
Next weekend.
Sir, next candidate Gayatri.
Yeah.
134 Gayatri.
1340.
1340.
Okay.
Good afternoon, everyone. I just share my screen. Is my screen visible?
Yeah.
Am I audible?
Yeah. Start.
Yeah. Good afternoon, everyone. Today I'm presenting a rare case presentation of bilateral ocular sarcoid. This is a case of about 60-year-old female who, just a second. Okay. This is a case about a 60-year-old female patient who presented with sudden painless diminution of vision in her right eye since 20 days. She also complained fullness around her lids in her left eye since 1.5 months. She was a diabetic under treatment with poor control. There was no other systemic complaints of cough, weight loss, fever, diarrhea, fatigue, or malaise. On examination, the best corrected vision in her right eye was hand movements and the left eye showed 612. The extraocular movements were full and free. On adnexa examination of the left eye, on inspection, we found fullness of upper lids, and on palpation, there were multiple non-tender firm nodular swellings, superior and superior-nasal margins. The pupil in the right eye was ill-sustained, the left was normal. The rest of the anterior segment in examination was normal with normal anterior vitreous also. So coming to the photographs, as we compare to the right eye, we can certainly observe and appreciate the fullness around the lids in the left eye. When we zoom in, we can see these nodular swellings on the upper lid margin, more on the superior. The rest of the anterior segment and the palpebral conjunctiva and cornea look clear. On fundus, the right eye, the media was clear, but the disc showed a massive disc edema with engorgement of veins, peripapillary splinter hemorrhages with a dull FRs suggesting of a fluid subretinally or in the macula. The left eye also, the media was clear, the disc looked normal, the vessel's architecture and the fovea had few RPE changes, but majorly it was normal. Coming to the multimodal imaging, the right eye OCT confirmed raised swelling of the disc suggestive of optic disc edema with multiple hyperreflective foci in the posterior cortical vitreous suggestive of inflammation, which we could not pick clinically or it was not evident, with the fovea and the macula had subretinal fluid. On the B scan, we can see there was a medium, low to medium hyperreflectivity over the optic nerve head, denoting of swelling and peripapillary fluid collection. So we've proceeded with investigations, and the relevant investigations which we found was MAN2 was negative. The ACE level showed 47 units, which was in the normal range. The HbA1c was 12.9. The MRI brain orbit HRCT was all normal. And so we went ahead with the tissue biopsy of the left upper lid nodular swellings. Simultaneously, we had started a right eye on posterior subtenance injection triamcinolone with oral systemic steroid of 60 mg with the relevant calcium supplements and the antacids. Coming to the histopath report, we can see there are the features of chronic granulomatous inflammation, which were showing a special stain reticulin positive with AFB negative. So we made a diagnosis of both eyes of ocular sarcoid. So the management, along with the systemic steroids, we added oral methotrexate, 15 mg per week, along with the folic acid supplements. Now we can see here at presentation, her vision was, right eye vision was hand movement, how the disc edema resolved. But unfortunately, we could not salvage the right eye as she had presented late and it went into the subsequent vascular occlusion, leaving the disc atrophic. But the left eye, we can see the fullness had resolved completely, the swellings had also subsided. So meanwhile, when the patient was under immunosuppression, she experienced slight blurring in her left eye again, and this disc showed slight hyperemia. So oral methotrexate was stepped up to 20 mg per week when the symptoms were improved and hyperemia was reduced. Currently, after 3 months, the patient is on oral methotrexate 20 mg per week, oral steroid maintenance dose of 10 mg per day, and she is stable with the OD vision of hand movement and the OS vision of 612. And since last 1 month, there is no recurrence or any new inflammatory signs. So the highlights for my case that this is a case of definite ocular sarcoid according to the diagnostic criteria of International Workshop of Ocular Sarcoid. This is also a purely ocular sarcoid, not associated with pulmonary involvement. This is a rare presentation as optic nerve involvement is seen in 1% of the ocular sarcoid cases. An extensive systemic workup is needed to rule out the secondary metastasis and a CNS involvement. Thank you very much, sir.
So what were your differential diagnosis?
Sir, we were thinking basically for looking at our age, we were considering secondaries as one differential, and in inflammation, definitely sarcoid and tuberculosis were our differentials. And we were also suspecting that it can be a neurosarcoid, so we had extensively worked her up. But fortunately, we could not find anything systemically. So this was a purely ocular sarcoid.
So what we can do in the management part to prevent recurrence in such cases?
Sir, we have kept her on optimum dose of immunomodulators like methotrexate. And since last one...
If they are intolerant?
Sir, we will definitely go for another immunomodulator. Or we will keep her on sarcoid in any acute attack. We will keep her on steroids in any acute attack. We will step up the steroids. But in our case, the problem with her, we could not, because of her high HbA1c and her general health being obese, we could not even give a 1 milligram per kg weight dose for her. So we have stuck to adult dose of 60 mg. And that is how we are stepping up the methotrexate to 20. She is quite tolerant and she is not recurred.
Okay.
Can an atypical mycobacteria present like this?
Sir, the AFB has come negative and there are no other HRCT findings also.
No, none findings.
Yeah, HRCT was absolutely normal. That's it. And very good response to methotrexate also. So,
does the skin test hold good even now for sarcoid?
Sir, MAN2 negative, we can think.
Squeams test.
Squeams test, sir. We are now, it is like an obsolete as it is a live.
Obsolete only, yeah. Nobody uses.
Yeah, because we are inducing the sarcoid by a live organism. So it is now no more Queen's test.
Thank you. But it's only a case report you have given, isn't it?
Yes.
Case series. Okay. Thank you.
No, sir, we have in literature where there was an
your presentation is a case report.
Yes.
Thank you. Thank you.
Thank you, sir.
Yes, Ashwin.
Sir, next candidate, Prabhu.
Yes, I'm.
Okay.
It's Pooja Prabhu, Dr. Pooja Prabhu.
Yeah, because it says only Pooja. Okay.
Sorry, sir.
No problem.
Yeah, should I start, sir?
Yeah, start and you can start.
So is my screen audible? Is my screen visible?
Yes.
You are audible and it is visible. No problem.
Okay, yes. Thank you. Good afternoon to all. Today I'm presenting on the topic occurrence of complications and need for drops in patients undergoing dropless cataract surgery. Cataract surgery is continuously evolving every year. Modern phacoemulsification cataract surgery claims to provide earliest rehabilitation to patients, and they can resume normal activities from the very day of the surgery. In spite of these advantages, one has to put eye drops in the operated eye for a period of 4 to 6 weeks, which can be confusing and expensive for the patient, taking away a lot of sheen from this procedure. There are also problems of compliance, improper eye drop installation, and frequent callbacks. Non-compliance to the eye drops regimen has been reported to be as high as 40%. This increases the risk of infection and poses a health safety concern. Dropless cataract surgery, a newly introduced technique of transocular injection of antibiotic and steroid, is a move forward to limit or eliminate this medication regime pre- and post-operatively. It is performed intraoperatively by injecting a triamcinolone and moxifloxacin formulation into the anterior vitreous space using a 27-gauge blunt curved cannula. This technique only needs one administration and the patient is not required to purchase a number of eye drops with various instructions. The aim of the study was to observe the occurrence of postoperative complications in patients undergoing this dropless cataract surgery and the need for drops in the pre- and postoperative period. It was a descriptive observational study carried out in the Department of Ophthalmology of Justice Case Hegde Hospital with a sample size of 20 patients from April to September of 2021 with universal sampling method. Intraoperatively, the pupil was dilated by injecting preservative-free phenylephrine, lidocaine, and tropicamide formulation. Then 0.1 ml, that is 4 mg of triamcinolone, was injected transannularly into the anterior vitreous along with 0.1 ml, that is 0.5 milligram of injection moxifloxacin intracamerally. Picture A shows intraop dilatation of the pupil as mentioned. Picture B shows injecting the triamcinolone transannularly, and the plume of intravitreal triamcinolone after injecting is seen in picture C. All patients were selected based upon the inclusion and exclusion criteria. Inclusion criteria being all patients who are undergoing cataract surgery, that is phacoemulsification with IOL implantation in the department. And exclusion criteria being known cases of glaucoma, steroid responders, cases that had complications intraoperatively, such as PC rupture, vitreous loss, zonular dialysis, unstable bag, and inability to deliver the drug, patients who underwent vitrectomy in the past, who are allergic to any component of the drug being injected, one-eyed cataract patients, patients with any corneal pathology, patients with a small pupil. A written informed consent was taken from all patients who were worked up in detail, including BCVA, slit lamp examination, IOP of both eyes, patency of the lacrimal system, dilated fundoscopy, and the IOL power was calculated using biometry. Standard surgical protocols and procedures were followed. Results: 20 eyes of 20 patients were included in this study. Of these, 45% were male and 55% were female. The age range of 51 to 90 having the most number of patients. On postoperative day 1, 4 patients complained of floaters, 15 of hazy vision, and 14 had reduced corneal clarity, which decreased to 0 number of patients after 28 days study period. Of these, UCVA greater than 6/9 was seen in 18 patients at the end of 1 month follow-up period. Of all the 20 patients, there were no cases of endophthalmitis, increased IOP, or need for drops in the entire 28-day study period. Discussion: the usual cataract surgery medication schedule can be confusing and expensive for patients, the main aim of which is prevention of infection and inflammation after the cataract surgery. Patients' inexperience with eye drops used showed poor installation technique by failing to wash hands, contaminating bottle tips, missing the eye, and using incorrect amount of drops, as reported by Jella and et al. A study by SP Chi indicated that due to this non-compliance, the patient's risk of endophthalmitis as well as other complications drastically increases. In India, this issue can be more serious as high volume eye camp settings have lesser number of ophthalmic and healthcare workers to educate the patients about good compliance. A study by S.K. Pandey et al. Stated the results of the survey conducted by the members of AIOS in 2014 that reported that 40% of ophthalmologists do opt for intracameral antibiotic administration. The entire pre- and post-operative experience for patients in the current study proved to be simplified and inexpensive, with no post-operative complications at the end of the 28-day follow-up period. This was in accordance with a study by Stewart et al. The findings of a study was similar to a study conducted by N. Bordeloy, where all the patients' mean IOP was normal at every visit and no patient needed any eye drops during the entire study period. Their study also reported patients being free of floaters at the end of the follow-up period, similar to our study where post-operative day 1 had 4 patients complaining of floaters, which decreased to 0 patients after 28 days. A study by Gangor et al. Reported patients to have higher IOP in the first week post-operatively, but no such instances were observed in our study. In conclusion, in the study, none of the patients required any eye drops throughout the study. Patients who initially developed hazy vision and floaters post-operatively were free of it by the end of the 28-day period, and there were no patients who developed endophthalmitis or raised IOP in the entire follow-up period. Patients undergoing dropless cataract surgery during our study did not have any lasting complications and were free of instilling eye drops, making the experience a hassle-free and smooth one. These are my references. Thank you.
So how did you identify the patients of steroid responders, who are steroid responders and who are not?
Actually, sir, only the patients who could give a proper history of having increased IOP after using steroid would be identified as steroid responders, sir. It's based on the patient's history or documentation, sir.
Mm-hmm. So there may be patients who are not on steroid and they will be exposed to triamcinolone now?
Yes, sir. Yes, sir. That is the limitation of this study, sir. We need a larger amount of patients, which we are carrying out, sir. We're planning to continue.
Okay. And you are giving this intracameral moxifloxacin. Any incidence of TAS?
No, sir. No, sir.
Okay. And you are saying you are giving this injection. So
Yes,
it was not in the exclusion criteria. So you are preferring it in the higher axial length or in the very pathological myopic eyes with liquefied vitreous?
So liquefied vitreous, we didn't come across any such cases. We didn't go for including such
But
patients.
that was not included or excluded in your criteria.
Yes, sir. Yes, sir. Actually, patients with shallow AC or myopia, we have We have 2 patients, sir, but there was no significant difference in their outcomes, sir, as compared to the rest of the sample patients.
Okay. Okay.
You are doing a study which is relatively new. Have you got an ethical committee approval?
Yes, sir. Yes, I have got it in November of 2020, sir.
Okay, the study was November of 2020. After you started the study.
No, sir. We had to get the approval with the abstract and then carry out.
Because your study period is still September 2021. 2021, isn't it? So you got it in November 2020.
November 2020.
Did you do any specular study on the risk on endothelium?
No,
because
sir.
you have taken a 90-year-old, I can see.
Yes.
Isn't it?
83, sir, is the
I thought
highest.
it was still 90.
No, sir.
Your slide said 90.
No, sir. I had taken the age range, sir, of like decade wise, I had taken. So 83 and.
But still 83 is,
yes,
how
sir,
much.
yes.
So that is one thing. And no posterior segment study post-operatively?
No, sir. No, sir.
Thank you, sir.
Patient didn't ask for any eye drops because normally all cataract patients, they will apply eye drops. They didn't.
Yes, sir. Yes, sir. We counseled the patients and explained during consent. We told them that this is a relatively new thing and explained the advantages, sir. So they were open to it. They found it easy, sir, on them.
Okay. Thank you.
Thank you, sir.
Next, can I call next candidate? Pradeep Sagar.
Good afternoon, sir. Are my slides visible?
Visible.
Yes.
I would like to thank the organizing committee, the judges, for giving me this opportunity. I will be presenting my paper on targeted laser photocoagulation of rim aneurysms in diabetic macular edema. Microaneurysms are the earliest clinical findings in diabetic retinopathy, and the leaky microaneurysms contribute to development of diabetic macular. Really small, but some aneurysms arising from the capillaries are known to be larger than the typical microaneurysm, and they are described in DME. It has been described variously as telangiectatic capillaries, retinal capillary macroaneurysm, and so on. So in this presentation, we will be concentrating on a capillary aneurysm with presence of a rim around it. So here we can see in this color photo, we can see an aneurysm with a wide ring surrounding it. It is seen as a hyperreflective rim with a hyporeflective rim on OCT. So in a retrospective study, we found that DME secondary to the capillary aneurysms with rim respond poorly to anti-VEGF and moderately to steroids. So the purpose of this study was to assess the efficacy of targeted laser photocoagulation in management of DME secondary to the rim aneurysms. This is a retrospective study. We included eyes with DME with capillary aneurysms with rim. We included both the treatment naive eyes and the eyes with poor response to intravitreal agents. The laser setting was 100 micron spot with a double frequency Nd:YAG. We identified the rim aneurysms on color photograph and confirmed on OCT, and laser was performed until a complete branching of aneurysm was noted. We followed up the patients every 4 weekly until the resolution of edema and 3 monthly after the resolution of edema. We included 9 eyes in our study. So let's discuss each case. Case number 1, this patient responded poorly to bevacizumab, and we can see that there is an aneurysm with the rim. After 2 months of laser photocoagulation, we can see that it is completely replaced by a sclerosed aneurysm, which is confirmed on OCT by the absence of a hyporeflective lumen. We can see that there is a complete resolution of macular edema. The patient did not show any recurrence till his last follow-up, which was 6 months. Case number 2, here we can see that there is presence of a rim aneurysm and a neurosensitive detachment. 2 months after laser photocoagulation, we can see that the aneurysm is barely visible, and we can see that it is completely occluded on OCT, and the macular edema is completely resolved. The patient did not show any recurrence till the next 6 months. Case number 3, this patient was treated earlier with multiple doses of bevacizumab and dexamethasone implant with poor response to treatment. Identified this rim aneurysm, and we treated with laser photocoagulation, and we can see 2 months later there was a complete resolution of macular edema with normalization of foveal contour and a sclerosed aneurysm. At 2 years follow-up, at 24 months, we can see that the aneurysm is sclerosed and there is no recurrence till date. This is the other eye of the same patient who was treated primarily with laser based on the good response in the other eye. We can see that there is a complete sclerosis of the aneurysm, and we can see that there is a normalization of foveal contour at 3 months. This patient had a recurrence at 18 months due to a development of a new rim aneurysm, which is responsible for the center involving DME. Case number 5, a similar response with a regression of aneurysm and a normalization of foveal contour, but had a recurrence at 12 months for which he was started on anti-VEGF. Case number 6, a good regression of the aneurysm, but the subretinal fluid is resolved, but there is persistence of intraretinal fluid at 3 months follow-up. So case number 7, we can see that the aneurysm is still persistent, the hyperreflective lumen is persistent, and we can see that the neurosensory detachment has resolved, but there is presence of intraretinal cystoid spaces. So a repeat laser was performed and is awaited for follow-up. Case number 8, the aneurysm, we can see that there is a loss of the hyporeflective lumen indicating closure, but the edema was persistent without any improvement. So it was switched to intravitreal therapy. Case number 8, 9, where we can see that there is an aneurysm, and 2 months post laser, we can see that there is hemorrhage around. On OCT, there is a complete occlusion of aneurysm, but there is no change in edema. So out of the 9 eyes with center involving DME, 5 eyes showed complete resolution and 2 eyes each showed partial resolution and no improvement. Visual improvement was seen in all the 5 eyes with complete resolution, and 2 of them showed recurrence. So out of the 9 eyes, occlusion was seen in 8 eyes by 3 months after laser photocoagulation. 3 cases were resistant to intravitreal pharmacotherapy prior to laser, which indicates that laser would be a better option and would be helpful in such cases. The limitations of the study are the retrospective nature, small sample size, variable follow-up duration, long-term risk are not assessed, and confounding factors such as the systemic status is not considered. To summarize, capillary aneurysms is seen in DME. It may be associated with poor response to intravitreal pharmacotherapy. It can be identified on color photograph and is confirmed on OCT. Targeted laser photocoagulation helps in good resolution of macular edema. So a prompt identification and laser photocoagulation of these aneurysms in DME is helpful in decreasing the treatment burden. Thank you.
The anti-VEGF used was only bevacizumab or ranibizumab or aflibercept were also used?
There are 3 cases and which were previously treated with the anti-VEGF. Among them, one was treated previously with ranibizumab and 2 other cases were treated with bevacizumab. Aflibercept was not used in any of these cases.
Any of the case, okay.
Can you stop share, please?
I have stopped sharing, sir. This is the next candidate.
Oh, sorry. Thank you. Okay. Sir, anything, sir?
No, I think you can.
I think so. We'll move on. Thank you, Dr. Pradeep.
Thank you.
Thank you, sir.
Sir, can I call next candidate?
Yeah, please.
Shantudas.
Hello.
Shantudas. Hello. Hello.
I can ask him to present.
Santanu Das.
Yes,
Dr.
yes.
Santanu Das, can you present now? Is this audio connected? I can't see anything there. His audio is not connected, I think.
Slide share also is not done, I think. No, slide share.
Yes, sir. No, his audio itself is not showing, sir. So he won't hear us.
Oh, okay.
Okay. Can we move to the next and then come back?
Better. Next, Ashwin.
Dr. Nagashri, isn't it?
Dr. Nagashri, sir.
Yes, sir.
You can start.
Yes, sir. Yes, sir.
Yes, ma'am.
Yeah. Go ahead. Yeah, you can start.
Is my slide visible, sir?
Visible, you can start.
Yes, sir. Good morning, one and all. Good afternoon for one and all, and respected judges. I thank for giving the good opportunity to present. I'm Dr. Nagashri from Basveshwara Medical College and Hospital, presenting a paper on ocular manifestations in rickettsial disease with the help of Chief Author Dr. Sunil Ganekal. Introduction. Rickettsial zoonoses are the infection caused by obligate intracellular gram-negative bacteria, which are transmitted by the bite of infected arthropods. Systemic involvement is characterized by the triad of high fever, skin rash, generalized malaise associated with the headache. Most of the patients with the ocular involvement are asymptomatic with self-limited course and hence may be easily overlooked. Ocular complaints associated are decreased vision, redness, floaters, or scotoma. Ocular findings in rickettsial disease include conjunctivitis, keratitis, anterior uveitis, panuveitis, retinal vascular changes, retinitis, and optic nerve involvement, posterior segment changes being more common. Ocular involvement associated with the rickettsial infection has a self-limited course but can result in persistent visual impairment. Though the rickettsial disease is common, there is a positive of the reports of the ocular manifestation in rickettsia, thus the study has been undertaken. So it's a retrospective analysis of the 50 patients with the rickettsial disease. All the patients with the clinical signs suggestive of the rickettsial disease with Weil-Felix test positive titer of more than 1:80 were included in the study. Visual acuity was assessed at the bedside for the bedridden patient and using Snellen's chart for ambulatory patient, and pupillary examination was performed. Patients were assessed for ocular alignment and extraocular movements. Anterior segment examination was done by slit lamp biomicroscopy and dilated fundus examination with slit lamp biomicroscopy and indirect ophthalmoscopy. Statistical analysis was done using IBM SPSS version. Qualitative data was represented in the form of frequency and the percentages, and quantitative data were represented using mean and standard deviation. Coming to the results, mean age was 12.5 plus or minus 9 years, ranging from 6 to 48 years. Total number of patients studied was 50, among which 27 were males and 23 were females. Single antigen positivity was found in 16 patients, that is, only one antigen was found in the patient's sera. Double antigen group positivity was found in 34 patients, in which 2 antigens were positive in patient's sera, in which OX2 being positive for the tick typhus, OXK being positive for the scrub typhus, and OX19 being positive for spotted fever infection. In our study, 37 eyes of 27 patients, that is 54%, had ocular manifestation, in which 17 patients had unilateral and 10 patients had bilateral manifestation. The most common manifestation being retinitis affecting 7 patients, that is 25.92%. And next most common manifestation was vasculitis and papilledema affecting 6 patients each. And next was the macular edema affecting 4 patients. The next was vasculitis with macular edema, papilledema with 6 cranial nerve palsy, isolated 6 cranial nerve palsy, and optic neuritis affecting 1 patient each. So this is the diagram depicting the posterior segment manifestation of the rickettsia. Diagram A depicting multifocal retinitis, that is yellowish white retinal patches. And diagram B depicting neuroretinitis, which is associated with the macular edema. And diagram C depicting juxtapapillary retinitis associated with the hemorrhage. And diagram D depicting retinal vasculitis associated with the macular edema. Coming to the discussion, our study showed ocular involvement of 54%, which was comparable with 2 other studies. And the most common manifestation in our study was retinitis and retinal vasculitis, which was 26 and 22%, which was also comparable with 2 other studies. The next were cystoid macular edema with 11% and optic disc edema with 4%, which was also comparable with the other studies. So conclusion, rickettsiosis patients can have ocular manifestation with predominant posterior segment involvement during acute phase of the illness. Ocular involvement was more common in the double antigen group. For any patients presenting with the fever and the rash living in an endemic area, ophthalmic evaluation should be a part of routine checkup during acute phase of the illness associated with the less frequent ocular symptoms. These are my references. Thank you.
What is the cause of Rickettsia infection in all these patients? Any etiology was there?
Pardon, sir, I didn't get it.
What is the cause of this Rickettsia condition in most of these patients?
Most of the patients had because of tick typhus, sir.
Oh, okay.
Which is caused by Rickettsia conuri.
Okay. Any questions?
You have given 4 photographs, no?
Yes, sir.
A, B, C, D. They are from your patients or from any other book?
Pardon, sir?
No, you have shown 4 fundus photographs.
Yes, sir. These are from the ambulatory patients, sir.
Okay, you should mention that, no, patient A, patient 2, like that, you know.
Yes,
You
sir.
have to mention that.
Okay, sir. Sorry, sir.
So, what is you are from which area? Is it endemic for Rickettsia area?
Actually, in central Karnataka, there are some 2-3 studies in which few villages in central Karnataka are endemic, sir.
Okay.
Central Karnataka includes Chitradurga, Tumkur, and Davangere.
You are in a multi-specialty hospital, medical college?
Yes, sir. Yes, sir. Medical
so
college.
from there you
Tertiary
picked up
care
50 cases, and
yes,
from
sir.
that you did the survey. Okay. But they did
Yes,
not
sir.
report to you with defective vision or anything like that.
Yes, sir.
So you picked up those cases and evaluated, or were they the ones which came to your eye clinic with symptoms?
No, sir. In our hospital only we have done, sir.
Okay. So you fix up the number of 50 and from that you got it.
From January we did till August, sir. So we had more number of cases during summer, like February, March, and April.
Thank you so much.
Thank you, sir. Thank
Dr.
you.
Arvind, sir?
No, sir. We can move on to next.
Thank you, sir. Thank you. Yes, Santanu, you can present.
Sir, am I audible, sir?
Yeah, audible and visible. You can start.
Yes, sir. Good afternoon, everyone.
Slideshow.
Yes, sir. It is in slideshow, sir.
No.
It is in.
Not yet. We are not seeing the slide.
No, sir. In my laptop, it is slideshow, sir.
No. We are seeing is your outline in this thing, and both you are seeing. It is not yet in slideshow. Probably you can stop share. You press that 4th button. So you are still in that. No, you have to stop and share again. We are not seeing slideshow.
Now?
No.
I think you will not be seen in that slideshow. No, you will be completely in some corner. You are seeing half of the screen.
You stop and then reshare and then start slide. Make it fast.
Okay, sir.
You have to stop share first.
One more candidate has made Aparna last. It has come by WhatsApp. Arvind and
Sir, can I call next candidate?
Can you stop share, Santanu?
Sir, one second, sir.
Can I call Vandana?
You do that, Shantanu. Slowly you do it. By the time we finish next candidate.
Yeah, but you have to stop share, Santanu. You can still see your slide PowerPoint.
Okay, sir. Now I stop.
Okay.
Can I call Vandana?
Come back, huh? Okay. That is 4th. Okay.
Vandana, are you there?
Can I share my PPT?
Yeah.
Good afternoon, sir.
What is 161? No.
Yes, 1161, sir.
1161.
Okay.
So can you see my PPT?
Slideshow.
Yes, sir.
Start. You can start.
Yes, sir. So good afternoon. Sorry for the delay. My topic for today is stereo acuity changes after small incision lenticule extraction. So stereopsis and SMILE. Stereopsis is an advanced visual function established on the basis of visual stimulus and binocular function, binocular vision. SMILE, since its first use in 2008, has developed growing popularity among ocular surgeons and has the potential to become the standard care for surgical correction of visual refractive errors. So coming to stereopsis, which is an important component of binocular visual function that has been largely overlooked in the field of refractive surgery. So in three-dimensional vision occurs when there is an amount of disparity between the retinal images in each eye, but not to an extent to which diplopia occurs. So coming to our aim of the study, we study the changes in stereoacuity after SMILE, study flow pattern. So we enroll the patients interested to undergo refractive surgery. Screening is done, and they have to be.
Ashwin, please unmute any other means. There is some background noise.
Ashwin, you have to mute yourself, Ashwin. You are unmuted. Yeah,
Ashwin
thank
is
you. Thank
unmuted,
you.
that's why.
Correct. Yes, thank you, sir. Yes, please. Sorry, I have paused there. You can continue.
Yes, thank you. The inclusion criteria, so patients should be a myope, age of 18 years or more, and the corrected distant visual acuity of 6.6 or even better. And patients should have a stable refraction for a minimum of a year. Exclusion criteria includes patients with corneal ectasia, any previous ocular interventions, any herpetic eye disease, or any scarring, or any history of trauma. So once we've actually screened the patients, we enroll them for us. We take consent and enroll them for our study. Here we've taken 40 patients for SMILE procedure. So coming to the surgical procedure, Visumax femtosecond laser system was used to perform SMILE. Following femtosecond laser parameters were used: 120 micrometers gap thickness, along with 7 to 7.5 mm diameter of the gap, and 6 to 6.5 mm diameter of the posterior lenticular surface was used. A 2.2 mm long corneal incision was made at the 10 o'clock position. A standard SMILE procedure was performed by a single surgeon. So coming to a pre-op workup, we take a detailed history with the systemic examination and the ocular examination with the following subheadings: the uncorrected visual acuity, the best corrected visual acuity, color vision, contrast sensitivity, and stereoacuity test, dry eye evaluation, pentacam, indirect ophthalmoscopy with peripheral indentation, and tonometry. So coming to our results, a total of 40 patients aged 18 to 34 years were enrolled in the study, and each of these 40 subjects, they have undergone SMILE. So the pre-op BCVA for all patients was 6.6 or better. Compared with pre-operative score, there were statistically significant differences in UCVA, BCVA at first week, week 4, and the 3rd month follow-up. The mean anisometropia in pre-op was 0.052 plus or minus 0.54 diopters, which was reduced in the following 3 months. So the result also includes the median pre-SMILE near stereoacuity was 70 arc seconds, which improved to 30 arc seconds. So conclusion is, usually myopic patients have slight stereopsis deficiency before refractive correction. SMILE surgery can actually improve the stereopsis. So near stereoacuity shows significant improvement after SMILE. Stereoacuity is associated with the degree of anisometropia, but not the amount of refractive error corrected. Thank you.
You can stop share.
I will stop.
Okay. Wait, Santanu, 1 minute. Sir, yes, sir, Dr. Arvind, sir, and Dr.
Yeah, means what were the results in the amblyopic patients?
So amblyopic patients, they didn't show much improvement because they had already a degree of anisometropia. So there was already slight visual deprivation, so there was not much of difference. But some patients who were not corrected fully, the stereopsis was better in them.
So in comparison to myopic, sorry?
No, sir. Sorry, sir. Please go.
In comparison to myopic versus hypermetrope. So in which type of population you would we can hope for the improvement in stereoacuity? And why?
Sir, so we've actually not done any studies on hypermetrope. We've only done on myopes.
Okay, only myopes.
Yeah, we've only done.
Okay.
But I thought your study, you included only 6/6 and better. So you would have not taken any patients with amblyopia, no?
We
in this study.
Sir, BCA best corrected were
6/6 and better.
Yes, sir. I
Oh,
mean,
yeah.
with glasses, sir, they were never corrected fully. So they were probably 6/9 with their spectacles correction.
I don't understand. When you say 6/6 and better, I thought it should be better than 6/9, no? BCVA, you said best corrected visual acuity of 6/6 and better, isn't it?
At some point, they won't have proper 6/6, sir. That is what they have complained.
That means you have to say 6/9.
Yes, sir.
Because it's a straightforward Snellen's. No, it's only absolutely objective and subjective to you. They're telling what. Okay. Yeah. Sir, anything, sir, Dr. Divakar?
No, I think she can.
Immediate post-op, do you think smile is better or femtosecond LASIK is better?
Smile, sir.
Really?
Yes, sir.
Yeah, on day one?
On day one also, sir, because
the clarity is better with
the clarity is
smile.
better, sir. On the same day itself, we see a better result. Like we keep them for about 4-5 hours with us. And the next day, they're much better. They're very comfortable, sir.
Thank you so much.
Yes. Thank you, sir.
Sir, can we move on, sir?
We can move on to Shantanu.
Shantanu is waiting. Thank you.
Yes. You can start sharing, Shantanu.
My screen is visible.
Slideshow?
Slideshow, can you put?
Yeah.
Again, some problem is there, no screen?
It's not coming. You're seeing the ring only.
Oh.
Go back to your PowerPoint. I'll tell you what to do. Go back to PowerPoint. Escape. Shantanu.
Escape from that and go back to the, without slideshow only you can present.
Ashwin, can you contact Shantanu and tell him to mail?
Connection is not good, sir.
Sir, I think
Tell him to mail his
network issue, sir. We got some network issue.
His image is frozen.
No, Ashwin, talk to him and get his PPT on your email address. Okay.
Okay, sir. Next,
Yeah, you
Anusha.
can stop his share.
Anusha.
Yes, sir.
Okay. Wait a minute. Anusha.
Yes, sir. Good afternoon, everyone. I'm sharing my screen now, sir.
What is your number, paper number?
Sir, 1204, sir.
The serial number is so.
Ainala.
Yes, Ainala Anusha, sir.
Ocular surface disorders.
Okay.
Go
Yes,
ahead.
sir.
Correct. Thank
Good afternoon, everyone. My topic for today is relationship between intensity modulated radiotherapy for buccal mucosal tumors and dry eye. The lacrimal glands or ocular surface provide adequate tears to lubricate the eyes and protect the ocular surface tissues. Any damage or disruption to this system will lead to abnormalities in the tear film, thereby leading to ocular symptoms. Radiation causes damage to the lacrimal glands, leading to cell damage, necrosis, and apoptosis, thereby releasing the inflammatory mediators, which decrease the tear production and induce dry eye. Usually, dry eye symptoms are experienced by many patients during or after the treatment by radiotherapy. Dry eyes can be categorized into mild, moderate, and severe, depending upon the severity of the symptoms and ocular signs. Tear film abnormalities are assessed by Schirmer's test, tear film breakup time, and tear osmolarity. Materials and methods. This is a prospective cross-sectional study conducted in Department of Ophthalmology, which includes 16 patients who underwent intensity modulated radiotherapy for buccal mucosal carcinomas. Among these patients, 56% were females and 44% were males. All these patients were treated with
intensity modulated radiotherapy with a median dose of 48 gray units. And all these patients underwent following ophthalmic examinations like tear meniscus height, tear film breakup time, measurement after installation of 5 microliters of 2% fluorescent sodium, ocular surface fluorescence staining of the cornea, Schirmer's 1 test without any topical anesthesia before radiotherapy and after radiotherapy at 1, 3, and 6 weeks respectively. Here are my results. Out of these patients, 6 patients underwent the mean radiation dose of 45 gray units, and 6 patients underwent a cumulative of 60 gray units. And the radiation dosage, the correlation of the radiation dosage, we found a p-value which is statistically significant for tear film breakup time at 1 week when compared to before radiotherapy and at 3 and 6 weeks of radiotherapy. Discussion. Patients undergoing intensity modulated radiotherapy for head and neck cancers may have increased incidence of dry eye disease, and the exact mechanism is unclear. In the treatment of head and neck cancers, radiotherapy can be used alone as a primary treatment modality or in combination with chemotherapy or as an adjuvant therapy following surgical resection. Radiotherapy-induced toxicity can be classified as acute, which is shortly after treatment, or late, more than 3 months after completing the treatment, and may significantly impact on patients' quality of life. So this IMRT is an advanced radiotherapy planning technique that uses non-uniform radiation beams that intensities to maximize the delivery to only the target volume while minimizing the radiation dose to the surrounding normal tissues. Studies have demonstrated that IMRT significantly reduced the incidence and severity of acute and late radiation-induced adverse effects, such as mucositis, xerostomia, radiation-induced blindness, and severe dry eye compared to conventional treatment. The incidence of dry eye disease after radiotherapy is considered to be dependent on the total dose of radiation delivered. Parsons et al. Demonstrated that the incidence of dry eye disease with a dosage of less than 30 gray units is 0%, whereas it was increased to 100% at a dose of more than 57 gray units. In a study conducted by Bandre et al., incidence of dry eye disease was 6% at 35 to 40 gray units, 50% at 45 to 50 gray units, and 90% at 60 to 65 gray units. Most of the studies have reported that dry eye syndrome begins to increase at a threshold of 30 gray units. Conclusion. In our study with a median dose of 48 gray units, 11 patients out of 16 patients developed dry eye with a p-value of 0.014, which is statistically significant at 1 week after radiotherapy. So all these patients were started on hydroxypropyl methylcellulose, and 6 patients had significant improvement in dry eye after 3 weeks, whereas 5 patients had improvement at 6 weeks post IMRT. Conclusion. The intensity modulated radiotherapy for buccal mucosal tumors is relatively safe to ocular structures, and patients develop only transient symptoms of dry eye, which resolve spontaneously. These are my references. Thank you.
How it can be prevented while doing the radiotherapy? Any precautions can be taken to prevent the dry eye?
Actually, sir, this in intensity modulated radiotherapy, it's not required, sir. But if anything like that, we can patch the eye and also can and the radiotherapy can be given. But the only thing in this intensity modulated radiotherapy, it will only focus on the lesions, sir. So it won't affect the surrounding tissues. So here the dry eye symptoms are only transient, sir. So not much precautions can be taken. Or now we can start them if they are on IMRT. We can start them on hydroxypropyl methylcellulose as a precautionary measure.
A good study, but you were missing tables and graphs in your study. And okay, which kind of means did dry eye was because of the aqueous deficiency, or it was of evaporative type?
It is due to the tear film secretions, because it might it can affect the meibomian gland lacrimal gland can be damaged, so that the lacrimal it can't be secreted. Because of that, it is affected. So mainly the dry eye is because of that.
Okay.
Actually, next student is Rishika, no? Neuro-ophthalmology. No, the Shantanu is there. Shantanu.
Shantanu is there, sir. Shantanu.
Start Shantanu. Yes.
It is visible now.
Yes, it's visible.
Slide share is visible. Am I audible?
Yes, yes, you are audible.
Okay, sir. Thank you. Good afternoon, everyone. Today I'll be presenting a case report on posterior medial canthal thermoplasty in the management of a long-standing case of facial nerve palsy. So the paper is co-authored by Dr. Saptagirish. The ophthalmologist may be the first clinician to see a patient who presents with an acute or a chronic facial nerve palsy. So under such circumstances, the ophthalmologist should make every effort to establish the underlying cause so as to ensure that the patient's cornea is adequately protected. So a facial nerve palsy patient can have various problems, like starting from visual drop due to corneal exposure, ocular pain or discomfort, chronic lacrimation and epiphora associated with paralytic ectropion, cosmetic disfigurement and difficulties with speech while talking, and also drooling of saliva while talking. So here I'm presenting a case, elderly gentleman who presented to us with a long-standing left-sided facial palsy, which was more than 5 years old. He had medial and left-sided medial and central ectropion. Lateral canthal tendon dehiscence was there. Medial canthal tendon laxity was there. There was left lower lid laxity. There was loss of forehead creases. Brotosis was there on the left side. Restriction of brow lift on the left side. 7 to 8 millimeters of lag ophthalmos was there, as shown in the picture. 3 millimeter of inferior scleral was there, and he was having exposure keratopathy, mainly of the inferior cornea. So we planned a surgery with the lateral tarsal strip with a lower lid patch graft, local anesthesia. So I have a video. So first we did the lateral tarsal strip procedure. So that is a lateral canthotomy and an inferior cantholysis is being done. Then sected up to the lateral orbital rim periosteum, and we had to fashion the lateral tarsal strip. So we took 50 ethibond sutures to anchor the lateral tarsal strip to the lateral orbital periosteum, but we didn't complete the procedure. We proceeded with the scleral patch graft. So here it is being shown how the lateral tarsal strip is being fashioned. So we proceeded with the scleral patch graft. Hello.
Ashwin.
Yes, sir. Yes, sir. Yes, sir.
He's got connectivity issue and video is also not playing.
Shantanu, forget about the video. You just tell us the steps, okay?
Yeah.
Yes, sir. Am I audible?
Yeah, you are audible. Forget about the video. Just tell us about the steps of the surgery and conclude. Okay.
Hello.
Sir, you have some
Network issues,
sir.
Network issue is very heavy, sir. They're not able to see the screen as well.
Yes.
Sir,
can I call next candidate,
Yeah.
Rishika?
Yeah, if he calls you, you try to connect, get the PowerPoint and do. We'll start from
Okay,
in between. Anyway, we will finish 2
Rishika?
minutes.
Yes, sir. Can I start, sir? Yes, sir.
Yes, you can.
Who's this?
Sir, it's
Your
Rishika.
ophthalmology.
Sir, the other participant has to stop sharing, sir.
Yeah, you can start now.
Can I start, sir?
Yes, please.
Good afternoon, everybody. I'm Dr. Rishika. I'll be presenting my study to assess macular ganglion cell complex analysis in compressive optic neuropathies and analyze its relation with perimetry. The background for our study was that automated perimetry is the standard for assessing visual function and monitoring disease progression in optic neuropathies. The macular ganglion cell complex, or OCT, is an objective, quicker, and repeatable method of assessing optic nerve dysfunction. According to studies in literature like Tigger et al., GCC is more reliable than fields or even RNFL analysis in chiasmal compression. The macular GCC parameters are theoretically superior over peripapillary RNFL parameters also in early diagnosis, because it has been experimentally demonstrated that RGC anomalies precede the axonal loss. Hence, we decided to conduct a study comparing GCC with visual fields. Our aim was to assess macular ganglion cell complex in compressive optic neuropathies and chiasmal lesions and analyze its correlation with automated perimetry. We included cases of compressive optic neuropathy, which were tumors compressing the chiasma, including cellular and supracellular lesions like pituitary adenomas, craniopharyngioma, meningiomas, which were referred from a neurosurgeon following complete neurological examination and confirmed on MRI. We excluded patients with the retinal pathology, patients who could not do a reliable field test, eyes with glaucomatous optic neuropathy or ocular hypertension in either eye. We studied 105 eyes of 53 patients in a tertiary care center meeting the inclusion-exclusion criteria from the period of November 2020 to November 2021. Patients' demographic details and history was collected. Complete ocular examination was done. All the patients underwent GCL analysis. A macular cube scan was done on a TopCon machine, and Humphrey's perimetry was done 30-2 with the size 3 stimulus. The results obtained were compared and analyzed. This is a sample data sheet where they've seen fields, RNFL, and even GCL in each quadrant, and global GCL values are taken. This is a patient, a 20-year-old lady who had pituitary adenoma. On the left side, the fields show a bitemporal hemianopia. The GCC correspondingly shows binasal thinning, corresponding to the bitemporal hemianopia. This is a 30-year-old gentleman with pituitary macroadenoma. The fields show a left homonymous hemianopia. The GCC correspondingly show a homonymous hemianopia. This is a case of a prefix lesion. Our results were 105 eyes of 53 patients. Our patients were aged between 16 to 62 years. Majority of our cases were pituitary adenoma, about 75%. This was followed by craniopharyngiomas, meningiomas, and one case of Rickettsia cyst. Our visual field changes were predominantly bitemporal hemianopia because of a chiasmal lesion, which could include superior dense, inferior dense, or center encroaching field defects. This was seen in 94.3% patients, followed by homonymous hemianopia in 2 patients, suggestive of a prefix chiasma, and junctional scotoma was seen in 1 patient. Our average GCL thickness was 62 micron, in contrast to a normal of 87 to 90 microns, and nasal GCL was the one which was commonly affected. On correlation with the visual field, 90% of our patients, the GCL was corresponding to the visual field effect. In 5% of our patients, GCL was worse or showed more changes than the field effect. And in 3.8%, field effect was seen more than the GCL. Our discussion is that in compressive optic neuropathies, we see 3 kinds of patterns. Firstly, there is significant correlation between the field effect quadrant and ganglion cell layer loss. In some cases, the GCL changes may precede the visual loss, allowing for earlier diagnosis and presumably better outcome. The reverse is also true in certain situations when the visual loss occurs suddenly, like a patient with chiasmal compression for a pituitary apoplexy. The visual field, because it's a functional test, will show changes before OCT can detect thinning on RNFL or GCC. Such cases call for an early intervention and probably may have a better visual prognosis. To conclude, GCL is quicker, reliable, and an objective tool is comparable to the visual field. GCL indicates the structural integrity of the optic nerve, while visual field is a functional test, and GCL and visual field should together be done as a part of assessment of optic neuropathy to assess damage and predict outcomes. Thank you.
Is there any study has GCL this normative data in Indian population?
No, sir. We have Western literature. There's a study where they've done a control of GCL thickness with the patients with chiasmal compression.
Okay.
I have a question.
Sir.
Are optic neuropathies and chiasmal lesions the same? You
No, sir,
mentioned
optic
optic neural disorders. No, I agree about your ganglion cell and the function and all those things. Your entire study is about macroadenomas, 2 prefix and 1 junctional scotoma. But you're mentioning about optic neuropathies. That's what I'm a little worried.
A study is only on optic neuropathies, compressive optic neuropathies.
Yeah.
Chiasmal compression.
Chiasmal compression, compressive optic neuropathy are the same or different?
No, sir, we studied only chiasmal compression, sir.
Okay, but you mentioned in your presentation optic neuropathies, optic nerve compression, that because you're getting binocular field defect in all your field defects.
Yes, sir.
Either junctional or homonymous, okay, or bitemporal.
Bitemporal.
Bitemporal. And that is the only question. Okay.
So mainly chiasmal lesions you have taken into study, no?
Yeah.
Only chiasmal
The
lesions.
terminology in your presentation, chiasmal neuropathies, chiasmal compressive lesions. We are talking about below, from below, above, all those things, you know. Because though you mentioned craniopharyngioma and all, you have taken only pituitary. No problem. Thank you. You are from a medical college or?
Sir, I'm a fellow associated with RIK, sir. This was a study of RIK and another tertiary care center, Satya Sai Hospital, sir.
Oh, they were the ones who were giving you.
Yeah, they were, yeah.
Good. All the best.
I think the last candidate on the contact
Shantanu Das.
Yeah, 1 minute.
Shantanu Das is
Sir, Dr. Divakar, sir, can we move on? Arvind, sir? Okay. You can start from where you left. Go to the video slide and skip the video slide. Shantanu.
Again, there's a problem.
Unmute
It's not
yourself.
open.
Go to the
Don't
video
go to the
slide.
video.
And skip the video. Skip the video. You have 3
Conclusion
more
slide you
minutes.
go.
Next slide, Ashwin.
You go to the conclusion slide.
No. You go to the next slide. Don't want video. Santanu.
Okay, because the surgery. Yes, sir. Okay, next slide. Okay.
You go to the conclusion slide. There is
Yeah, go. Because the 3 minutes, 3.5 minutes, you have finished already. You can go ahead. Next.
So, yes, sir. So this is the pre-op picture where the inferior scleral show can be seen, and the post-op 2 weeks where the inferior lid is at the level of the inferior limbus, and the medial canthal tendon laxity has been corrected, and the lag of ophthalmos has reduced to about 2 mm from 7 to 8 mm in the pre-op period. So what is this posterior medial canthal thermoplasty? It works by creating a directed posterior lamellar scar. So this technique involves a posterior lamellar diathermy where the burns are given between the medial canthus and the medial end of the tarsal plate and sparing the canaliculus as well as the lacrimal system, the punctum. So PMCT works on the principle of reattaching the dehisced Horner's muscle to the tarsal plate. So this technique is simple, quick, and it is minimally invasive without any external scar. The canaliculus and the lacrimal apparatus are preserved, unlike with medial canthal resection procedures where we need to sacrifice the punctum as well as the canalicular system. And the posterior medial canthal thermoplasty, it induces more fibrosis than any medial canthoplasty procedure, so which can potentially increase the duration of the effect. And posterior medial canthal thermoplasty can cause less visible scarring and symblepharon. It is also simpler and less invasive. So this is the study that I have referred to, where they have taken 77 patients with paralytic ectropion as well as involutional entropion, and they have done posterior medial canthal thermoplasty as a combination procedure in combination with lateral tarsal strip or a mid-face lift or a spacer graft. So here they have noticed 90% improvement in epiphora post-surgery, as well as 85% of the patients said that their inferior lid was at the level of the inferior limbus. So the lid sagging has also improved in 85% of the patients, and they didn't find any symblepharon or any scarring in the post-op period at about approximately 16 months. So posterior medial canthal thermoplasty is a safe, it's a simple and an effective procedure which reduces the medial canthal tendon laxity. It preserves the canaliculus as well as the lacrimal drainage system, and it can be used as an alternative to medial canthal resection procedures. So where we are sacrificing the lacrimal system And definitely, if we sacrifice the lacrimal system, the patient will have continuous watering. Thank you.
So in what type of ectropion this procedure is more helpful? Paralytic ectropion or cerebral ectropion or?
Sir, in my case, we have taken a paralytic ectropion. So why we have selected a paralytic ectropion? Because here the facial nerve is paralyzed. So the supply to the orbicularis muscle is fully paralyzed. The tone has reduced to the minimal possible. So that's why we have selected, because it produces a scar. So the scar will be able to hold the Horner's muscle to the tarsal plate for a longer duration of time. Previously, we used to do the medial canthal resection procedures where we sacrificed the canalicular system. But this procedure, which is a relatively new procedure, and there are no Indian studies on this. So this procedure, it preserves the canalicular system, the lacrimal system.
And how this fares in the long-term period? This laxity is reduced, means in the long-term follow-up period?
Yes, sir. Actually, this is a case which we have followed up till 1 month. We are still collecting cases. We just wanted to report this new surgical technique. At 1 month, my patient had very good, the lid laxity has definitely improved. Whatever pictures I showed, so it was at that stage. So status quo was there. It was at the level of the inferior limbus, and the lag ophthalmos was approximately 2 millimeters. So it was at one month.
Good.
Yes.
Okay. Keep your internet connection good. Okay.
I'm sorry, but I couldn't play the video only. That's the main thing.
Thank you. Otherwise, your time would have exceeded. Right now, you finished on 6 minutes.
Yes.
Thank you, Santanu.
I think one last candidate is a contact lens.
Yes, contact lens.
One patient, one student number, Asha has sent in the group.
995.
995, yes.
Sir, I'm here, sir.
Yes. Because presenting more.
What's your name?
My name is Aparna Bhaskaran.
Okay. Thank you.
My slide.
What is the topic of your study? Smart
comparison of smartphone visual acuity with traditional Snellen lens chart.
Okay.
Are my slides visible, sir?
Yeah.
Yes. Please go ahead.
Slideshow and start.
Good afternoon, everyone. I'm Dr. Aparna Bhaskaran. I'm going to present our paper, Comparison of Smartphone Visual Acuity with Traditional Snellen lens chart, which our co-authors, Dr. Mahesh Babu, Dr. Abhilash P, Dr. Sudhagar N.A., and Dr. Dikshita V. Visual acuity assessment is an important in diagnostic and prognostic evaluation of any ocular pathology. What is the need of our study? This COVID-19 restriction and fear of contracting infections have made most people to opt for comparatively safer option of COVID-19 restriction and fear of contracting infection has made more people opt for comparatively safer option of teleophthalmology than in-person hospital visit for non-emergency complaints. But what's the greatest barrier in the teleophthalmology is finding a reliable and feasible alternative for Snellen lens chart which is commonly used in clinical settings in India. A few individual studies conducted found that visual acuity measured by smartphone apps are comparable to the standard charts. But most of these studies are done in volunteers and their effectiveness in an actual patient is inconclusive. The reliability and effectiveness of most of these acuity tools in standard clinical testing condition is lacking. So we plan to compare smartphone application, that is iChart in iOS platform, peak acuity in Android platform to the traditional Snellen lens chart to explore the possibility of using them as an alternative in teleophthalmology in current COVID-19 pandemic. So we done an analytical type of observational study on 360 eyes of 184 patients attending an outpatient department of ophthalmology in a tertiary care center in South India from August to October 2021. We have used simple random sampling technique to select the patients. In the inclusion criteria is people above the 18 years of age and willing to participate. And these include the patients with emmetropia, refractive error, cataract, pseudophakia, having visual acuity better than 6/60. We have excluded the patients with gross ocular pathology and whose visual acuity is less than 6/60. So visual acuity was assessed by 3 methods in random order in a same room and lighting condition using a tumbling knee optotypes by a single examination. Self-illuminated Snellen stat measured visual acuity at 6 meters. Peak acuity app installed on Samsung Galaxy M30 measured visual acuity at 3 meters. The eye chart application installed on iPhone SE measured the visual acuity at 1.4 meters. Visual acuity was assessed monocularly with one eye occluded. Each test was repeated 3 times. Median value was selected and noted for the further analysis. Acuity measure was converted to logmar units for the ease of statistical analysis, and statistical analysis was done using IBM SPSS statistics software version 27. So these are the results we got, and the median age of the patients in the study was 39.59, and most of them are 50. Females, 50.5% were females, and 68.5% had educational qualification beyond matriculation. This is the clinical and visual profile of the patient. 60% of the patients were emmetrops, around 27 becomes a refractive error, 10% were cataract, and 3% were pseudophakic patients. Then we did a statistical analysis for comparing eye chart, peak acuity, and Snellen chart. We have used one-way ANOVA with post-decay HSD test for the comparison. And from the p-values, we can see that there is no statistically significant difference in visual acuity measured using eye chart, Snellen, and peak acuity, with F value 2.5411 and p-value is 0.0793. And then we did a subgroup analysis. The emmetropic data was not satisfying the criteria for ANOVA, so we have used Kruskal-Wallis test with post-decay HSD test. And we got the following result. The visual acuity measured by peak acuity was not statistically different from Snellen in any subgroup. The eye chart, it was statistically different in emmet, but not in other subgroups. Then we did an intra-class correlation coefficient. And the intra-class correlation coefficient, most of the values in both groups, it was 0.9. It was 0.9. So we can tell that there is a strong positive correlation between eye chart and peak acuity with Snellen in total values, also for the subgroups. And this plot is the correlation plot. Here, the thick line, this is for eye chart and Snellen. This is peak acuity with Snellen. And this straight line indicates the linear regression. Then we have to know the limit of agreement between the methods. We have used Bland-Altman plot. For plotting this Bland-Altman plot, we had measured visual acuity, mean difference in the visual acuity. Then 95% limit of agreement was calculated using the formula plus or minus 1.96 standard deviation. So this is the Bland-Altman plot we have got. We have plotted for total and also for the subgroups. And here, the x-axis will represent the average logmar acuity between two methods, and y-axis will represent the difference between the two logmar visual acuity difference between the two methods. The thick solid line, the green line, indicate the mean difference, and the dotted line indicate the 95% limit of agreement. And from this Bland-Altman, we can see that the mean difference or the bias, what is mean difference is bias, is positive in eye chart, and while it is in peak acuity, it is negative. And this mean difference will be increasing in the patients with reduced vision. And if you are comparing the limit of agreement, we can see in cataract and refractive error patients, the limit of agreement is more. So if the limit of agreement is more, then the consistency of the result with the Snellen will be less. So in cataract and refractive, results will be less comparable, but still they are in
Your time is up. 6 minutes over. Okay, go ahead. Finish.
A median difference between visual acuity was 0.0 logmar, and for emmetrops and refractive error and cataract. This is a chart showing the percentage showing no trend of the visual acuity different, percentage showing no difference is more in the both group. Difference between eye chart and Snellen chart when present was mostly positive, while difference between peak acuity and Snellen chart when present was negative. Percentage of patients showing difference in visual acuity increases in eyes with refractive error and cataract. Our studies show that there is no statistically significant difference in visual acuity measured by 3 methods: Snellen, eye chart, and peak acuity. Pairwise comparison also gave the same result. Eye chart and peak acuity showed strong correlation and limit of agreement with Snellen's chart. This is consistent.
Kindly conclude.
So we concluded that our study suggests that smartphone-based apps, eye chart and peak acuity can be used as an effective, reliable, feasible alternative to assess visual acuity in teleophthalmology, especially during these pandemic times.
Why in the first place you didn't compare Logmar with means on the smartphone app?
Sir?
Why in the first place you didn't use the Logmar acuity measurement along with the smartphone app?
We have used log, sir, everywhere.
Stop screen sharing.
No, you have said Snellen's visual acuity. That is not
Yeah,
the
we
goal.
have taken the Snellen's value, then converted it into Logmar value, sir. Because Snellen's chart is used because that is the commonly used chart in the.
Can you stop your share?
Okay, sir.
What type of smartphone is used for this?
Sir, for Android, we have used Samsung Galaxy M30, and in iOS, we have used iPhone SE, sir.
Okay. Any other questions?
No, sir.
Okay.
No, sir.
Okay.
So thank you all of you, sir. Can we ask them to leave, sir? All the candidates?
Yes, sir, definitely.
Yeah, all the candidates can leave now. Ashwin?
Sir, yes, sir.
Except the 3 judges.
I spoke to...
All of you can quit. All the very best.
Yeah, all the best. You all are champions.
Yes.
All of you did well in your own way.
I spoke to Elon. He told to send it to the group, all the Excel sheets. He will tabulate it and finalize it.
Yes, sir. Yes, sir. That's what I have also marked. I will send it to him directly, I thought.
Better
Only,
not to the group.
Anyway, no problem.
Yes.
Yes, sir.
Directly to whom, sir?
Yellen.
Right, sir. Okay, I will do that.
That will be better.
Not to the group. I think no need to send to the group. He told to.
Yeah. We must
directly. So he can compile it.
Okay.
Nice meeting you, sir.
Very nice meeting you, sir.
Yeah. Where are you from, sir? Dr. Arvind, sir?
I'm at Sir Ames, BB Nagar, Hyderabad.
Hyderabad. Oh, nice.
Oh, okay.
And Dr. Divakar, sir?
I am from Bangalore and I am ex-president of KOS. I am the president, Bangalore Ophthalmic Society president actually.
Okay, sir.
Ilan Kumar is secretary and I am president of Bangalore.
Which hospital, sir?
I was in Ramaya College, only in Shankarai Hospital actually.
Oh, okay. Now I am with Arvind Coimbatore, sir. I am from Tamil Nadu.
Great,
I am doing online work. So nice meeting you all. My birthplace is incidentally Bangalore, sir.
Okay.
Nice meeting you both, sir. Thank you so much.
Very nice meeting you, sir.
Thank you. Ashwin, thank you so much. Yes, sir. Ashwin, thank you so much. All the best to all of you.
Thank you, sir. Thank you.
Results will be officially announced.
Okay. Ashwin, you can close it now.
Okay, sir.
Okay.